صباح الخير يا دكتور يسري.
من زمان.
دكتور يسري صباح الخير.
Just testing audio from the theatre. Could anybody confirm that they can hear us? Test. 1, 2, 2, 2. Why didn't it work before?
Try again.
Good morning, everyone. Just testing audio from theatre. Could somebody just confirm that they could hear us?
Unmute. Unmute. We didn't hear you.
We're going on the mic.
There we go.
Oh, yeah. We connected you in the past.
Yeah. So if you speak now.
Rahman Basha. Assalamu alaikum.
عليكم السلام ورحمة الله وبركاته. صباح
Can you hear
الفل
me
يا
well?
باشا.
Sabah Gamal.
Yes.
They told me that only there are 6 people
صباح
who are.
الجمال.
They told me there are only 6 people now. So are we ready?
No. All of them are in the waiting room. Can we admit them now?
So we're gonna be willing to start in 5 minutes. I will do introduction, and then Tom will take them through the tower, the laparoscopic tower we are using, and then we're gonna start the surgery itself. So
we will allow all people to go in now.
yes,
Okay.
and then I will make introductions like for 5 minutes, and then following that, Tom will like have a chat about the tower that we are using and some of the stuff that, particularly the smoke extraction that we are trying today, some options, and then it will be like we're going to get the patient in. While we are getting the patient in, I will take them into the office. So we'll talk about surgery itself. And once the patient is ready to start the surgery, we're going to start the surgery. So the way we are now, introductions, 5 minutes Tom in theaters with the tower, and then back to the office where we're going to take them through the first case and what we're going to do, and then back to theater, we're going to do the action. Is that right?
Yes.
Thank you very much. Yes.
You can keep that.
عملته unmute.
افتح الكاميرا لما
السلام عليكم.
وعليكم السلام دكتور أحمد.
معايا أحمد باشا.
والسلام ورحمة الله.
وعليكم السلام ورحمة الله بروفيسور.
بص
يا باشا اتفضل يا باشا.
Assalamu alaikum, everybody. Thank you much for joining us today. We hope it will be useful and productive. So what we're gonna do is we have today 3 cases to show you, and we're gonna start first. I'm gonna ask Tom, the medical physics, to take you through the laparoscopic tower that we are using. And then, of course, I'll be back again to start with the first case. So the first case is laparoscopic hysterectomy. She's a lady of known endometriosis, adenomyosis. She had before history of ablations, and the plan is to do hysterectomy and one side of hysterectomy. And I think the aim of the surgery, I know that it is a fertility course, is to focus on the anatomy and the basic skills of laparoscopy. So you will see details about the anatomy and indeed all the skills that you need to master when you do laparoscopic surgery. Of course, the setting, the ergonomics, the positioning of the patients, the organization of the team, the tray of the instrument that we are using, which should be like, again, we're going to try to do this in a very in a slow and easy way. So you will see how easy that you can achieve laparoscopic surgery so long as you know what we do. And the second and third lady are patients of endometriosis and tubal problems. So these are, I think one of them is known to have extensive adhesions presented with pain and fertility. The IVF is unfeasible, and she wants to have her tube. She got hydrocephalus as well. So it is for pain and fertility purpose. And the third patient is patients who is known to have extensive endometriosis and adhesions and also fertility. And her priority is pain and fertility. So you will see again in these 2 ladies how you can develop a strategy, how you can use the laparoscopy meaningfully. I think yesterday, day before yesterday, I did lectures about the entry and about the and about the basic skills. So today we're going to demonstrate that. So when we start, we're going to demonstrate the cross entry technique or adding to it modifications of the optics as well. And in one case, we're going to demonstrate the palmar entry, and hopefully in the third, we demonstrate the open entry. So you guys see the 3 types of common entries. All right. And we will be able to communicate. So I will try during the surgery to focus on the important bits, again, of not only developing the strategy, but more importantly, to get the skills in the right way. Everybody happy with that?
Yes,
Yes.
thank you.
Good. So do you have any question before we start?
No, thank you.
The screen is very interesting because some of you guys are eating, which is fantastic, make a beautiful day. So again, what I'm trying to say to you is, because there are many people watching the link, so if you are not interested actually to show what you're doing or what your family is doing, you put the camera off. So what I'm saying is, this recording as well on YouTube. So some of you guys showing the kids or the parents, some of you as well showing themselves or enjoying themselves on bed or eating, which is good. However, having said that, it will be recorded on YouTube forever. So be careful when you look at, because
كلمي معاها كده في
what we're doing
جماعه المديرين على
if I'm you, I will
الفلوس بتاعت الست.
actually switch the camera off. تمام؟
Doctor, please, can the admin switch all the cameras?
I think this is a good idea.
The admin can make all the cameras off, only the
camera.
Yeah, please.
Cameras, because as I said to you, some of the guys having a screen where actually there is some private scene, which I don't think it would be appropriate for them to keep it recorded on YouTube.
Yeah, please, doctor. Thank you very much.
Islam. To Ahmed.
ماشي.
Yes, sir.
So I think what they are saying, can we switch all the camera, apart from the camera of this computer, the camera from the theater? All right? Good. So I'm gonna stop myself now, and I'm gonna hand it over to Tom, and Tom will take you through the tower we are using, and then we're gonna have a pause for 5-10 minutes to get the patients in and do the setting right, and then we're gonna start operating. So hopefully, after the demonstration of the tower, we'll need 10 minutes or something, where get everything in place, and then we'll start positioning the patients, and we'll start our transmission again.
Doctor, please, regarding the arrangement inside before the patient entrance, can we also take a quick idea about it? How we are arranging the rooms before the patient, the arrangement of the room before the entrance of the patient. What is in our room and this thing?
It's very important. The reason why we do the live link today is not like to get you the surgery itself, but also to show you the details of sitting. So all the aspect of sitting the patients, positioning the patient, setting the diathermy, the pedals, all the stuff which exists in the different room, you will see it very clear. And I like you
Thank
to
you very much.
That, because this what will make your surgery much easier and safer.
Okay, thank you very much. Can we also take a quick idea about it?
السلام عليكم. Hello. عليكم السلام. Yusri, excuse me. I leave the meeting because report for me that I'm removed by the host. I talk from my friend telephone. Can you accept me, please?
Unfortunately, the limited number of participants is 100. You can view this broadcast using YouTube.
Okay. Thank you.
Morning, everybody. Tom from Carl Storts. Can you hear me this time?
We can hear you. Yeah, carry on.
So, Tom from Carl Storts, my colleague David Clark here. So, we're helping Mr. Rafiki today with the live streaming using the camera system already in place, which is the Carl Storts Image 1S 4K Rubina camera system. So, the camera system is a full native 4K imaging system. We'll be using the endoplater 50, which is a high flow rate heated insufflator, and we'll also be using smoke evacuation as well to maintain the surgical image today. With the power LED Rubina light source, which is an LED white light Rubina light source with a dual infrared light, LED as well, so for any ICG procedures that you'd like to do as well. The camera system is actually able to record in 4K completely as well, and we'll be streaming to you today via this team meeting and through YouTube as well. So if you've got any questions about Carl Storts imaging equipment, please let me know, and we'll be happy to help.
Sorry, please, the voice is not that clear.
I'm sorry, we're in the operating theatre moment, just setting up, so for the time being, that's the best speakers that we have at this moment in time. We'll be setting up the speakers for Mr. Rafiki very shortly.
Yeah, Ahmed, can we switch all the cameras for all the people, please, apart from my camera and from the camera on theater. في دكتورة في الكاميرا على طول شغالة بتاعتها دكتورة. Can you please switch all the camera off? Can everybody switch the camera off? There is a yes, apart from my camera and from the theater camera, the rest of the cameras to be off, please.
All cameras are switched off now, Dr. Afi.
All right, that's fine. Thank you very much. Carry on, Tom. Tom. Oh, you need to switch. Tom. Oh, yes, excellent.
Hello.
Yes, carry on. Carry on. We are listening.
Oh, no, sorry. We've completed there for the camera system. So we've got the 4K Carl Storts Image 1S camera system today, full 4K technology. And we'll be also using the high flow rate heated insufflator with smoke evacuation for surgery to maintain and improve the surgical image during surgery. So the system is full 4K. It has ICG properties as well, components, so that we can do ICG image overlay through the 4K imaging that we see on the main screen. And we're actually able to record in full 4K as well from that side.
So Tom, can we show them the insufflators, please, and yes, please. So if you take them through the insufflators buttons and what we do normally for the beginning, setting the pressure, etc.
We certainly can. So
and also, if we just also explain the new easy smoke extractions, quite cheap new adventure that you are producing today as well.
So the endoplater 50 that we'll be using here for the insufflation is the endoplater 50. So the properties from this device, we can actually flow CO2 at a rate of up to 50 liters per minute. So it's a high flow rate insufflator. This device as well has the availability using this port here to actually heat the gas once it enters the patient, so which reduces the post-operative shoulder pain in the patients, whilst also maintaining an improved surgical field of view. What we have here, we have the flow rates and the pressures. So with this tubing, we can actually increase the flow rates whilst maintaining, or we can increase the, or sorry, decrease the pressures whilst increasing the flow rate to potentially try and decrease the amount of pressure required for laparoscopic surgery from here. What we'll also be doing for this type of surgery as well, we'll be using a passive smoke extractor, so that with the increased flow rates of the insufflator, we'll be actually expelling smoke generated from electrosurgery inside the cavity, so that we maintain a perfect field of view, so that we spend less time coming out and cleaning the laparoscope during the procedure, so that we can operate continually. So the rest of the imaging system looks as so. We have the LED light source here. We have the AIDA unit, which maintains and controls the patient management, information management, and the camera control units from here as well. And together, we have the full camera system with 32-inch viewing monitor from here. We're just going to set up in surgery now, so we will be back from the operating theatre shortly.
All right, guys, can you hear me?
1, 2, 1, 2.
Can you hear me?
Yes, sir.
Yes,
Yes, sir.
yes, sir.
All right,
But
so,
without the picture.
so the first lady that we're going to start, she is now going to be exercised in a second. She is in her mid-40 and she got problem with pain for some time. She's known to have endometritis.
Doctor, we cannot hear you now. Please.
There is no voice. No
Can you hear
voice.
me now?
Yes.
Now okay.
Yes, yes, yes.
Okay.
So the first lady who is currently going to be exercised, she is a lady who is in her mid-40. She had 2 surgeries before for treating endometriosis. She also had before endometrial ablations for managing heavy bleeding, and she's still having bleeding and pain problems. So the decision was taken that she needs to go for a hysterectomy. The pain is mainly on the right side, so we're going to remove as well the right ovary, leaving the left ovary behind. So we're going to do a hysterectomy plus right salpingoophorectomy plus left salpingectomy. As you know now, currently when we do hysterectomy, we like to remove the tubes as well as routine, simply because there's some good evidence suggestive that removal of the tube reduces the risk of ovarian cancer later in life. And so long as a woman's losing infertility potential by having the hysterectomy, and we know that removing the tube will not compromise the function of the ovaries, so you can safely remove the tube to reduce the risk of ovarian cancer long term. So she will go for normal entry, which if you remember what we discussed 2 days ago that we discussed the close umbilical entry, and we agreed that close umbilical entry is for any patients who got normal BMI, but if the patients had BMI of 18 or less, then umbilical entry is contraindicated. It is acceptable for patients who didn't have high risk of adhesions underneath the umbilicus. So if there is no midline incision, if there is no multiple transverse incisions, if there is no previous surgery suggestive extensive adhesions, then you can go for the umbilical entry. And close entry means that we're going to use Barras needle to insufflate the abdomen, followed by the trocar to get the optic inside. And we agreed last time about how we can make the close entry absolutely safe from the risk of vascular injuries. And we discussed and we confirmed that we need to be certain of the distance guided layers insertion, which means we know that in the umbilical bit, which is the lower, the bottom end, or the most lower bit of the umbilicus, there's only sheath and peritoneum. There's no much fat, there is no muscle. So irrespective to the body belt, irrespective to the fat, the umbilicus is more or less the same in the different individuals. And from that sense, we know that the distance between the bit of the umbilicus and the blood vessel is more than 4 centimeters, which is more than enough in most of the patients to get the entry successful and safe. So we stick the needle vertically into the umbilical incision, either to go through the 2-click sign or to stop at 4 centimeters. And we're going to show you today how to hold the needle and how to insert it. And then to check that you are inside, we agreed that we do the Balmer test, which is good because actually it will help to dislodge any fat or obstruction at the tip of the needle. It also provides few drops of saline, which if being sucked easily and smoothly suggested negative intra-abdominal pressure. However, it is not the most reliable test. The most reliable test is the entry pressure. This is why we agreed on Saturday, we have insufflation pressure. We normally set the pressure of the machine to 25 millimeter mercury, which means that the machine will carry on insufflating the abdomen till the pressure becomes 25. We agreed that the entry pressure has to be less than 8, which means that it confirms that you are inside the peritoneum. And so this is the most reliable test. So if it is the case, then we'll carry on with the insufflation till the pressure becomes 25. By that mean that there is a bubble of gas underneath the umbilicus, which is at least 4 centimeters with the high pressure force, which allow us to insert the trocar vertically using 2-hand technique. And we're gonna show you how to use a 2-hand technique. You can put the camera into a trocar because all the relatively new trocar having this opportunity, which allow you to add to the safety of the entry as well. And this, once you are in, you stop, and we agree that we have to stop further insertion or swinging of the needle while you're doing the entry. So this is the entry that we're going to try, the first one. And after that, we insert the second, third, and fourth trocar. I think we agreed last Saturday that it is anterior subilateral spine, 1 finger from it. This is where the second bolt is. And then at the same level in the midline, this is where the third bolt is. And because we are stitching vaginal bolt at the end, so we need to put this para-umbilical, the fourth one on the right-hand side, more than 5 centimeters from the midline, because we agreed that the pubigastric vessels lies 5 centimeters from the midline. And you're going to see exactly the position of the trocar from outside and from inside, which allow you to safely insert the trocar. You're going to see as well how we are positioning the patients, and we agreed that we have to keep the arm on a side, and we'll show you this to you. And also we have to slightly flex the hips, which allow the free movement of the instruments while you're doing your surgery. And the patient has to be kept in flat positions till full insufflation is happening, until you check the site of entry. And once you confirm that there's no bowel injuries, you ask the head to go down. And once you change the patient positions, you start seeing the pelvis, and then you start doing your surgery. Because we're going to do hysterectomy and we're going to do oophorectomy, so we're going to use the opportunity of showing you the anatomy, but not only that, the easiest way of removing tube, and this will help you when you do the injector for ectopic. We're going to demonstrate to you the easiest way of doing oophorectomy in case that you are doing oophorectomy ovarian cyst. And we're going to try a different approach, so just in case if there's a difficulty of getting the access. So whether it is transperitoneally or retroperitoneally, and you're going to see all the time that the surgeon is operating by his or her two hands, which is the left hand and the middle both. And then you've got an assistant which is holding the camera by the left hand and the right hand for the right port, and you've got the second assistant which is on the bottom. For the hysterectomy, we're using a certain type of uterine manipulator called VCare, which is disposable one, which has the advantage of a colbotomy cup, which allow to stretch the phonesis, anterior, lateral, posterior phonesis. So this will actually take the vagina away from the ureter to reduce the risk of ureteric injury, but also it will outline the phonesis rightly, so you will not remove much of the vagina, which is helpful as well. It's very easy, it's quite cheap, and it is disposable as well. And we're going to show you how to insert it. It is simply a uterine manipulator which has a balloon at the end. So you insert inside the uterus, inflate the balloon so it will be self-retaining, and then you advance the green colbotomy cup, followed by retaining blue holders, which keep the cup stretching the phonesis while you're doing the colbotomy. So this is the uterine manipulator. We're gonna energy devices. Today we're gonna show you, we're gonna use the bipolar, the monopolar diathermy, and we're gonna see the setting of diathermy in my theater, which is normally 50-50-50. We're gonna use for vessel sealing a device called Thunderbeat. And Thunderbeat is simply a combination of advanced bipolar system and harmonic ultrasound, which is fantastic for sealing and fantastic as well for dissections. Having said that, if you don't have this advanced stuff, you can still using the normal bipolar, monopolar. You can use other vessel sealing devices like Ligasure and seal and harmonic and so on. There is a lecture on electrosurgery and energy devices, which I hope that maybe in between the cases we'll be able to provide the lecture for you, which is a very concise lecture about the understanding of the electrosurgery and how it can be. You're gonna see me as well how I use the bipolar and how I use the monopolar for cutting. And again, this is extremely important skills for all reproductive surgery, as this will be an opportunity for you to be able not only to achieve endpoint hemostasis, but also immediate hemostasis when it is required. And with the monopolar diathermy cutting, I'm gonna demonstrate you how to do the clean cut. And I think I mentioned this on Saturday, that you can use diathermy for achieving a clean cut. Clean cut means a cut with a viable edge, so you don't damage the tissues while you are cutting it, so you end up having pink edge after the cut, not white or not black. And we're going to see, I'm going to demonstrate to you the difference between that and between the bad one as well. What I like you to focus today is not how good or bad I am a surgeon. I like you to focus on actually how I address problem during surgery and how I try to overcome the difficulty by developing a strategy. How I use my assistant as well, and how I try to make my life while I'm performing the surgery easier and safer. And I like you to focus on the small bits, and you're going to see me, for example, showing you where I have bought my diathermy pedals, which is again something which you might see that actually is very why he's showing this to us. But when you try it, you will see it will save nearly a quarter of your operating time by just placing the diathermy pedals in the right place. All right. So again, there are some cameras which still open, which I really suggest, because as I said to you, some of the open camera is really not careful about what they are showing. So I think for the sake of everybody satisfactions and safety, maybe switching all the cameras, but the two cameras are showing. Now, I'm going to hand it over to Dr. Lena, who is my senior registrar, and she's going to be my assistant. She's going to demonstrate to you the V-Care and the instrument that we are using quickly. So you will be like familiar with the tray. So let us, are you happy with that, Lena?
Yes, we just moving the patient to the table. We're just moving the patient to the table.
All right, so all right, that's fine. Let's move the patient first and have a few minutes. All right, that's fine. I'll carry on talking then. Thank you very much. So we're moving the patient in now. So once the patient is in, we're gonna stop. So let me take a few questions before we start. So if we open the mics and if anybody open the mic only, not the videos, and if anybody got questions before we make the first patient starting. Dr. Ahmed? Islam?
Yes, sir.
So what I'm saying is if anybody got questions, first there are people saying that there is no voice. Can everybody hear me well?
Yes, sir. We can hear you very well.
So now if there's anybody has a question for me before we start, we can answer it. So till they get the patient in theater. Now they are getting the patient in theater. So we have 5 minutes or 2 minutes where we can actually answer
Excuse me,
questions.
Dr. Yusri, I just want to know regarding the position of the patient and the position of the camera, position of the
The
orientation. Yes.
Don't worry about this bit. I guarantee that you will know exactly the positioning of the patients when the patient is in.
Because it's different from each operation. According to the operation, I think
No, it is the same in every operation. So the good news is the position that you're going to see now is the position that every patient come to my theater will be in.
Okay. Okay.
Once you know the position of the first one, you will see it in the second one, you will see it in the third one, the same position.
Okay.
Any more questions? All right. That's very good. So what we're gonna now move in. We're gonna move to theaters. I think the patient will be in now. So I will leave you. I will see you on the other side on the theater in 2 minutes, where we're gonna take you through the stuff. All right? All right, guys, can you hear me well?
Yes.
Can you hear me?
Yes, we can hear you,
Good stuff.
but no live cam.
Yes, we will do the camera in a second. So, Lena, you know what I'm going to do is we're going to open the phone. I think if we do the camera phone, it's better. No, with normal camera phone. If I get you my phone, I'll get you my phone. You're right. Yeah. So Islam, I'm trying to, I like to activate, Islam,
Yes, sir.
I like to get in through,
Hello, Dr. Afifi. You are muted, Dr. Afifi.
Hello. اسمعني كده مستقيم.
Hello.
Hello. في مشكلة. هو سنوي في
Recording in progress.
to show them. Can you hear me, guys?
Yes, sir, we can hear you.
So I like to use the camera on my phone.
No, it's not clear.
Because I like you to show the outside bit with a better camera.
No, we
than
cannot
the
hear
normal
you,
camera.
sir.
Can you do that? Can you see my phone camera?
No.
There is no video. The voice is coming, but there is no video.
No video yet.
تمام دكتور يوسف.
From my camera.
The voice also is very, very faint.
Can you mute here? Good stuff. So
Yes, now we can see you.
So let us start. Good. Let us start now. So if you want to hold this. So let us show you first.
Doctor, sorry, we cannot hear you.
Can you hear me now?
Yes, the voice is clear as well as the video is coming.
Good stuff.
No, even the voice is not clear.
All right, let us start. Can we show you now first? This is the actual positioning of the patient. You see that we keep the arm on the side of the patient like that, not like over the chest, because this will help with the camera movements. We'll keep the head slightly flexed, patients in flat positions. So the first step of the surgery is insertion of the V-care. V-care is the uterine manipulators, which I mentioned to you. So what Dr. Lina is, as you know, my grasp the cervix, and then we're going to show you now the V-care. So there are sizes of the V-care, so it depends on the size of the cervix. So if the cervix is normal size or big, we'll go for the big one. If it's small size, we'll go for the small V-care. So this is how the VK is, and Lina will show it to you now.
So this
So,
is
carry on.
so this is the VCare uterine manipulator. So you've got a shaft that follows the sacral curve. This is for easy insertion. And as you can see here, this is the injectable port on the side. And at the end of it is the inflatable balloon. And what it does, once you inflate that balloon, it helps to keep the uterine manipulator, the VCare, in place. And then you've got this green cup. That green cup sits on the cervix, and it allows easy manipulation, and it guides you during your colpotomy when you open to remove the uterus and the cervix. So what we're going to do, I'm going to deflate the balloon from the side, from the injectable port side. Then when you insert it, as I said, it follows the sacral curve and to allow anteversion and retroversion of the uterus.
You dilate. So she dilated the cervix first, and she might need to do further dilatations.
So the uterus is anteverted.
You know, she
If
had
we could do the camera, will be better.
So we need one voice for communications. So my suggestion is we unmute everyone. Everyone who wants to say something, both in the chat, and then Islam or whoever is controlling on the other side can talk about exactly what the problem is, just to avoid having many voices at the same time. So this is now the first part. She got the get in, so she's gonna inflate now the balloon. Good. And following that, she's going to take the stems off. She's going to advance the colpotomy cup. So the patient had ablation before, she might have adhesion inside the uterus as well. So there's normally risk of operation with that, but we'll see how it goes. And now she got the, after that, she push it as much as she can, and then screw it. So we'll end up saving this. This is uterine manipulators. All right, I'm gonna leave this here for a second. Let's start, and then I will.
شكلها مش متعودة على النت.
Whenever you're ready. I can just do it from the button from here. Okay, brilliant. Let me just do it. Zoom in. Give me 2 seconds. Just point it towards this one again, please. Brilliant. And then just twist it. Certainly can, yeah. Push it back down that way, yeah, right.
And we have to take it down. That one there.
And then this will come down over the foot.
Professor Afifi, for some reason, the video disappeared.
Right, so you see that.
Can we put the smartphone in landscape position?
So this is the position you see now. The arm on the side, not on the chest. Thank you. And the head is slightly flexed, but down enough so you can manipulate the way you like. The height of the bed, as you can see now, adjusted. So it's me and my assistant and the camera. You can see the camera. We normally place it just above the left foot. Just put the camera this way. And you can see, and then adjust the screen. So in that case, if you have one only camera, which is very common, then it's placed the monitor just above the
Was
left
there
foot
a fast filter?
in a position where you and your assistant.
Yes, of course.
Actually, have to wait.
No.
We're going to do, as I said, 3, 4, 3. So if we come closer, this is what like this. So when you do your incision, you hold the umbilical like that. You go into the base of the umbilicus, which is the bottom end of the umbilicus, go in out the skin, and you do 11 millimeter cut. All right. So you see, even when it heals, you become inside the bed itself, which will make it more cosmetic. This is a varus needed. I check that actually there's a spring. It will make the gas to be certain that the tube is opened. So Tom will open the gas on.
Gas is on.
Gas coming. Perfect. Please. I'm going to ask him to set the pressure to 25. He will see now the pressure is on 25, which is insufficient pressure. Then I hold the needle. There are 2 ways of holding the needle. Either holding this way, so you get 4 or 5 centimeters from the temperature, 4, or this way if you have a short hand. So let us do that. Up, then you go in, 1 click, and then another click. And we'll see. We'll stop at the 4 centimeter. And then we'll put some saline in, and see saline goes in quickly. So this biomark test, then we'll connect the gas. And then we'll ask the gas to be on to check the pressure. I show the pressure. See the pressure, it's 8. I lift that one up. And it's 2, which means that we have pressure is 8, which means that you are in. So keep the insufflation. So keep down the insufflation. Tell the pressure. Now we put it in diathermy. So we have bipolar diathermy. This is the rule which is commonly used. And then you have the subbeat, and you have the hop. We get the scissor and section irrigations. This tube, which actually is something which we start like, it's allowing the high flow of the gas, and also with a valve which allows good smoke extractions.
And heated.
And heating. Thank you, sir. So it has the advantage of extraction of the smoke, which is hazards, which allow you as well to provide reduced diathermy.
If we cannot see the operation, cameras fix it. We can hear voice only.
We haven't started the operation yet. So you've seen the needle, you've seen the incision of the needle. Now, this is the trocar. Can you see the trocar? Can you see it?
No, I cannot see. I cannot see.
We can see. We can see. I can see.
We can see.
Video is.
So
We can see.
We use 2 hand technique, which means that you get like that with the right hand. You close your hand like that. And the other hand is 4 centimeters from the tip, which again providing the extra safety, making the risk of vascular injury not existing. So we carry on with the insufflation till you achieve the pressure. While we're waiting, I'm going to show now the diathermy with the sitting. You might put it on the side. And this is quite important as well. So I like to set the diathermy pedal where without me looking to my feet, I'll be able to. So I use the bipolar or very close to my left foot. The monopolar cutting is close to the table. So without me looking, I can do that or I can do that. So it's very important to get the diathermy pedal where actually you can use it without using your eyes. Perfect. Remember, the patient is still in flat position. So what we're going to do now is we're going to shift the screen. Now, once we send it to car, it is
to the laparoscope.
And then we're going to go to the laparoscope setting with the voice. So what we're going to do now is we're going to switch off my external camera. So we're going to focus now on the internal camera. But just before we switch off complete external camera, can I show you something? For this is the umbilicus, we agreed on that. This is the anterior spine. So what I do is ASI, middle finger, and then the left finger will be where the second port is. And then you put this thumb, and this is where the third port will be. And this is the ASI, this is where the fourth port will be. But if you are stitching, you need to be para-umbilical more than 5 centimeters from the midline. So you're going to see us once we got the main camera in, we're going to check the site of entry to be certain that there's no bowel injury. And then we're going to start placing the second, third, and fourth trocar in to start the operation itself. The pressure now is 20, so it's creeping up. Once we are happy that it is above 20, ideally 25, then we can place the bolt, the trocar. Good. So we've done white balance for the camera. And now we are ready. And you can see the pressure now is 24. And now we are ready to put the bolt trocar in. 10 millimeter, please. So as we agreed, hold like that in the middle, and then screw it in gently till you are in. Once you are in, you see the gas is flowing. So we're in now. No further, no swing. And then you connect the gas again. And then what Lena will do is she's going to get the camera in. The patient still in flat positions. Now we see that we didn't have any injury. Now we're going to put the head down, please. We're going to switch the top light off, please. And then we're going to show you now the insertion of the bolts. Can we clean the lens, please? And can I have the table up a little bit as well? Yes. So head down to the maximum you can give to me and table up. So can I, anti-fog, please? Table up. That's fine now. That's perfect. Can we have the legs a little bit lower as well? Guys, can I have the legs lower? So you see now the first port in, I'm gonna come lateral. This is the SI, and then this is my finger, which allow me to see that inside there is no adhesions underneath. So I can, knife please, can do the first 5 millimeter. All right, the same level. I'm gonna do the second one. And then because I'm stitching, then Lena will do one bar umbilical more than 5 centimeters from the top. Then we're going to get 5 millimeter inside. And once we get all the bolt in, you see the tab, then screw it gently like that. You can see the balloon. We're going to inflate the balloon in a second, the second one. Good stuff. And then we're going to do the third one. And once there's some adhesion on the side, good. Now we're going to inflate the balloon of all the bolts, 5 millimeters. And we can, once you are in now, then we drop the pressure to 12. Now this is the manipulators. Can you give it to me? So when you do that, like that, you can see the uterus. You see these sterilizations, which is holding the tube to the abdominal wall. Give it to me. Just trust me. Just hold it like that for a second. Just hold it like that. All right, perfect. So now on diagnosis, let us make diagnosis first. So you can see uterus. I think the cup is not very much inside the uterus. I think it needs to be inside the uterus a bit more. So you can see now, if you look at that, I think we need to adjust the cup inside the uterus. But let me go through the anatomy with you. So this is the clip. You see some adhesions here, which are holding the tube, the abdominal wall. This clip here, and you can see the tube. Oh my goodness! You see that one of the reasons why she's having the pain on the right side, obviously now seen that very interesting views that the bit of the tube which has been sterilized, so the rest of the tube is there, is actually separated and become tauted around itself and become necrotic. See that? And this hasn't been seen actually on the imaging she had. On the imaging she had, because actually this is not, see the ovary is intact, so they've seen the ovary all right. The tube, there's one clip and there's another clip, and it seems that this clip cut through the tube, and then the bit of the tube which has been cut, which is already having no blood supply, it started to twist around itself, become necrotic, causing a lot of pain. All right? Yeah. So what we're going to do first is, of course, you need to remove these adhesions. No, you are not inside the uterus. You see that? You can see that, you know? So you are actually in the cervix. No, you are outside. You're perforating. You are perforating. So remove it. And gently now inside the uterus. All right, so gently now, get a dilator first in to see exactly that you are inside the uterus. Again, and look at the screen. Yeah, that's fine now. Yeah. So you see the reason why this lady had pain on the right side was that very surprising event. But also she got some endometriosis on the pelvic side wall. This is a batch of Douglas, and we're gonna look at the depth and look underneath the tussical ligaments to make a full diagnosis. You see, I have to lift that to see the underneath, and this is close view. And then you do that to see that there is a defect in the batch of Douglas, which could be on the endo. On the other side, this is the tussical ligament. We're going to see the ureters in a second. Once Lena is happy, no, you are not in yet. You are outside here. Dilate well to the uterus. There's an ablation. This is why you are actually struggling. It's good to see problems. So the problem is because she had ablation and adhesion inside the uterus. So you see that when she's starting, you're outside actually. Get the catheter. 1 second. Get the catheter. Yeah, give me the catheter. Yeah. Have it. Take your time. Can we clear the camera? You're right, Lena. All right. You are in now. Perfect. So carry on dilating more. That's fine. More. Yeah, don't be afraid. Don't be afraid. That's fine. That's fine. Good. Press in. So are you happy to see the screen well, guys? Can you see the screen well?
Yes, Professor, yes.
Can you see the
Yes,
screen
sir.
well?
Yes,
Do you have assurance that that you can hear me well and you can see the screen well?
Yes, the
Yes,
voice
sir.
and the video
All
are
right.
clear.
Yes, sir.
Good. You're in now. You're in now. Good, yeah. So you see, this is again some defects here, old endometriosis, some endometriosis again. Arch of Douglas, this is the depth which I was talking about in the lecture of diagnostic laparoscopy. They have to get the insert, which is 2 centimeters or more, into the arch of Douglas to be sure that there's no obliterations. This is the rectum, and this is why this is called rectal configurations. We're going to see in a second the ureter, and you can do this transperitoneally, you can do this retroperitoneally, and all what you need just to come to the IB ligaments. Once Lena finished, we'll show you now. This is the cup, which is coming. You see now you can start seeing the cup here. So you can see a cup on the back. This is osteophonics, and you can see cup as well. Perfect. Cup on the front. And this will make actually your surgery very easy and safe. If you come to the IB ligament and to the pelvic here, you're going to see the ureter. If not, then we're going to do retroperitoneal expiration. So let's do some work. Have this light off, please. Well done, Lena. So if you just like that now. So let's start with the, remember, we're going to remove the right ovary. We're going to leave the left ovary, but we're going to remove the tube on the right side. This is the round ligament. All right. So let us start now. Hold this for me. Good stuff. Now, if you see the front here, you can see the cup, you can see the round ligament, if you like that now. Good stuff. Thunderbeat, please. So I'm going to show you now what we do normally. So this is, you see Lena show me the round ligament. So with that, you activate and cut. And when there's a smoke, you go a little bit lateral like that and this in. And then you do that. And then you do that. And then you do that. So this is the uterovesical fold. And then you do that. Good. And then back again, and she will do that. We're going to do the tube, because actually, and then we're going to look at the ovary. So that, and with the tube, if you are very close to, so with the grasping, you can see, let me show the anatomy for you. If you grasp the tube up like that, you're going to see the blood vessel, which is underneath the tube. You're going to see place, which is avascular. This is where we need to go. So rotations, and go to the, just above the arcade. Good stuff. We're going to keep the clips as well, remove it as well. Perfect. So we have the tube now taken out. Then we're going to do the tube ovarian ligament. But now we need to check where the ureter is. Now I move the Thunderbeat to the side. Back with the camera, please. So what Lena is doing now is, this is the IB ligament. Then we have to see it 1 centimeter towards the pelvic prim. This is where the ureter has to be seen. Back with the camera. Back with the camera. I see myself, no, back. Yeah, good stuff. Now, let me go that here. So let us see now where we can see ureter or not. If not, we have to go retroperitoneally. You can see this is the ureter here, moving, peristalsis this way, so it's away from us. Back with the camera again. So from that sense, I'm going to do the IB ligament now. I'm going to leave the ovary on that side. Leave this to me. Can you hold this for me? Like that now? Good stuff. So this is the ovarian ligament, guys, the tube ovarian ligament. I'm planning to remove that, saving the ovary as much as I can. So what I do is like that. Perfect. And you can see there are some connections here, which again, I know that the ureter is away. So let me cut that. So you see, we'll do 3. And once you cook well, you cut. Yeah, yeah. Good stuff. Good stuff. Now you see that what I've done now is I got the ovary away, then I'm gonna go to the posterior. The camera is tilted, Lena. And when I do that, I'm heading to the uterosacral ligament, which is here, and this is the cup here. And I've seen the ureter before, so I separate more of that to allow me to skeletonize the uterine at some point. You all right? See if there's a bleed. I use the bipolar on the side to control it. So all the time I am in control of the game. This is the cup on the back here, so I'm cutting it. Perfect. Let's just come here. Can you hold this for me? Can I have this? Like this now? Now you're going to see that when you look at that, you're going to see a little bit of unnecessary stuff, small blood vessels, which I can cut, because this will allow me to skeletonize the uterine very well. Ureter is away completely. So from the front here, which we'll come to it in a second, where actually the uterine need to more skeletonize, and you come this way, you can see, start seeing the uterine clearly now, but we'll wait till we do a full reflection of the, can you hold this for me? So can you hold this for me? Now we're gonna go to the other side, the same. Again, back, this is the round ligament again. And then I'll go instead of Lena. Then again, reflect the peritoneum on the back here. No, hold this for me. So can I have this for a second? Just like that. Good stuff. Back with your camera a little bit so I can see what I'm doing. Good. So this is the bit of the reflection that I've done before. This is the cup here. So this is where I'm going. So you go in and allow the guest to do the dissection for you. And finally, the final bit. Good stuff. And when you do that, you can see, you can feel the cup. And back with the camera, please. Hold this for me. And I'm going to remove the tube and ovary on that side. So what I need to see, hold this for me. What I need to see now, I need to see the ureter. So we need to remove this at the end. So let us see where the ureter is. So this is the IB ligament. And now, if you come to the IB ligament here, and you have to see, this is the ureter here. You can see that. So you're going to see where it's going. Going this way, this way, this way, this way. It's far away from us. So we don't have to do extraperitoneal explorations. So what we're going to do now is we're going to do the IB ligament this time. We're going to move the ovary on that side. So this is the ovary. I always say hug the ovary and do 3 buzzes. First one close to the ovary. You start with that before you cut. And then you go down a little bit. Half centimeter, you are more than 5 centimeters away from the ureter, so you are safe. You can see there's no smoke because the beauty of this valve, which actually make the life easy for us. And once I'm happy that I cooked it very well, we cut it. Good. And then do relative abstractions. From now on, I hug the ovary. See that? Cook. Cook again. And then cut. Then hug the ovary. Cook. Cook again. And cut. Cheap leader, you do it before you go. And again, the same. Good stuff. There, come closer. Once you come closer now, you see this is the peritoneum, which we need to separate it because we need to skeletonize the uterine on that side as well. So I will do that. Yeah, just see that this is the cup, this is the uterosacral ligament, this is the uterine here. So what I'm going to do is I'm going to ask Lena to go in this side, Lena, this side. And so she'll do that for me like that. So I can see now that where I'm going, this is uterine. I need to separate here. So I need to go and separate to skeletonize completely the uterine. Good stuff. Beautiful. And this is the uterosacral ligament. Beautiful. Back with the camera. And you see there's a small bleed here. Bipolar on both sides of the bleeder. And then activate. Bubble is formed, bubble will collapse, bleeding stop. See that? See that? So we are happy now. So what I'm going to do now is, can I have a scissor, please? I'm going to reflect the bladder so we can go to the step which is everybody worried about, which is you can see the bladder. Scissor, please, on bipolar and scissor. So what we're going to do now is bipolar. So you can see this is the cup here. This is the bladder and this is the reflection. So what we need to do is, again, I'm not looking on the pedal because I know exactly where they are. I activate the bipolar first, and then I will do a bit of scissor. You are pushing through the anesthesia as much as you can. Good, and once you do that, you push this gently. Again, diathermy. That's fine. She's a little bit vascular because of the history she had, but that's fine. As long as you're in control of what you are doing, then the expectation is, because you are in control, you can see the cup now clearly. And I think the bladder is far away, so we are fine from that sense. So we're going to start now skeletonizing both uterine on each side. Thank you. So we're going to start with that side, so like that. So you can see now what's happening is, you can see the front here. This is the cup, all right? You can see the back here, and you can see in between, this is the uterine complex. See all of that. So what I'm going to do is I'm going to do this bit by bit to be certain that actually, yeah, that's perfect. Good. Standard beat, please. So we're going to see now that I'm going to do that using the cup, using the I'm going to do this with the bipolar first. I'm inside the cup now, so I know that I'm very safe. So I got the bipolar with me as well. So just in case if there's any concern, I do that. Section, please. Good. Now the section on, please. So we nearly done this side. Good. And in that case, I like always to make this perpendicular, lateral to the cup itself, and do the final bits of the uterine complex. Beautiful. All right, let us do the other side. Hold this for me. So in the other side again, the same. To the front, you see the back. So we know that this is all the uterine here. So reduce it first on the cup, and then inside the cup, this is the backflow. This is again backflow. And then backflow. You can see from the other side, the bipolar will come lateral to the cup again and do final bits. Then what I'm going to do, I'm going to go now from the middle port where I have access to be using the cup constructively, like that. Can you hold this for me? Good. Can I do this? Just push that like that. Good stuff. Good stuff. Just a bit of speed here, so you control it. Some from the backflow as well. Can you see the front? So the cup is still not clear on the front here. So yeah, trying to show bleeder. Yeah, so we'll do that here. Again, this is in the cup. It's again in the cup. Good. Now, can you hold this for me? You can see now more of the cup as you see from the front and back, and nearly the uterine done now. So I think we're gonna do this bit here because this is part of the uterosacral, which hasn't been cut yet. You can see even the green of the cup. Good. Now can I have the hook, please? Hook. Anatomy hook. Then we're gonna now do colpotomy. So we've done the uterine, we finished nearly. Thank you very much. And see what I said before about the cut is if you touch like that, this quag, see that? It goes quag. But if you act here before you touch and you start cutting, it becomes cutting a clean cut. That's what we mean by clean cut, which actually having little quag in it. So I'm cutting now on the top of the cup. See the front? Hold this for me. Yeah, good, excellent. So you see again all the time, you're on control. We cut on the cup itself. Other side gently now. Hold this for me. All right. Hold this for me. Like that now. Good stuff. No, don't move much. That's fine.
Dr. Usually the cup at the internal os.
Good. Antivent a bit. Good stuff. Back with the, can I see? Can you see the front here? Good stuff. And this is to complete the colpotomy.
Dr. Yusuri, what is this ring? What is this ring? The green ring?
Gently. Good. So now we remove the uterus. So what we're going to do is we're going to take this like that. So the vagina. Put this one in. Some bleeder here. Like that. Now get the top light on, please. Get the Sims. Gas off, please. Gas off. Can I have a traumatic grasper, please? Yes, please. All right, yeah. Perfect. Thank you very much. And can you see the cervix? Can you see it? Good.
No, we cannot see it, sir.
I know. This is, we're taking it from the vagina now. All right, yeah, carry on. Take the Sims off. No,
Where is the cervix here?
Take this off, and then this will like that. Cabatrotic grasper again. Stay in the vagina for a second. Cabatrotic grasper. Another grasper, please.
Usually the cup at the internal os.
Gas on, please, again. Now take all the uterus off, please. Uterus off, and clean the vagina and put swab and stick swabbing gloves in it. Changing the gas because we're running out of the gas, so we're going to stop for seconds.
This is to complete the colpotomy.
Yeah, put the swab in the gloves. Medium swab first to clean the vagina. Medium swab.
What is this ring? What is this ring? The green ring?
No, just put it in your finger. Yes, clean the vagina well. All right, and after you clean the vagina, put the swab in. Yeah? Good. Now, light off, please, on the back, and gas on, please. Good. So you can see now that we're going to check if there is any bleeder first. So what we're going to do is we're going to grasp this edge here, to the front. And then suction irrigation for me and bipora, please. So I'll see if there is any bleeders which need to be secured before we do the stitching. Bipolar, what's that? So go in. You can see the small bleeder here. Some bleeder here as well. I think this will be coming with the stitch anyway. Good, stitch, please. Give me 2 Stratifex, or number 1, give me 0 Vicryl, 2 0 Vicryl, please. I'll put it here with the vagina. Go in. No, that's Vicryl. You can use Stratifex, which is a bob stitch, or you can use normal Vicryl stitch that we're going to use now. Where's the bead is coming? I think there's a bead for the front. Can I see? Oh, it's from here. Interesting. So this, I think, from perforations. All right. So let's have the you know, in the beginning there was a little bit of perforations with the difficulties. Can you see? So this is need to be stitched. Oh, this actually where it's bleeding from. All right, that's fine. Stitch, please. So grasp the front bit, front wall of the vagina. Get a traumatic grasp in your hand. Good, stitch, please. So let me show you how to get a stitch nicely. So you see, this is how to place the needle, curve against curve on a side like that. And then you get into 5mm bolt as normal. You go into the camera of this one here. And can we clean the lens, please? No? Yeah? Needle holder, please. Can I have the table up a little bit, please? So what I'm going to do is, you got a grasper, show me the front, so take the stitches. Up a little bit, please. So you see, this is my position. So we place the needle, we adjust it. So there is something different from the time, because if Lena put a traumatic grasper on the middle, please, she will show you that there is a bit of the vaginal tear, which happened during the insertions before. Traumatic, one with teeth. So what I'm going to do is I'm going to stitch this first before stitching the vagina. Rotate. Good. And now I can see. So I rotate my hand like that. Then transverse, and you do two bites, two hitches. Then you go closer, and you do that. And then the other hitch. Then we're going to carry on. Good. Remember, this is a vaginal tear which happened during the mandibular insertions.
it has, this is what we are doing it first before we starting closing the colbotomy bit. Yeah. Good. So you see now, because we've done that, you see the bleeding now settle down. Yeah, scissor please. Then we're going to start closing now the vagina as normal. So normally you will always have a problem during surgery. So don't panic. Try to figure out how you can overcome it. Oh, please. How to overcome it and how to be sure that you are safe as well. So we'll do that now. And what we're going to do is we're going to do suction irrigation after that to be sure that we're in control. And what I'm going to do is I'm going to use the rest of the stitch to secure the angle on my left-hand side while we're here. Yeah. So you see, this is now, I think it's better, but we'll see. That's fine. Good stuff. So now we'll go with the securing of the other angle, the angle which is my angle. Middle holder, please. And again, a traumatic grasp in your hand, so we're going to alternate. So you see now, I'm going to use my left hand for stitching because I'm going to secure the angle on the left-hand side. Traumatic grasp, please. We're going to take the clips from the vagina at the end. So you see now, this is the edge of the vagina. All right, do you agree? Then I'm going to take that from in out. Then that under vision, everything under visions. And that. Then when I do that, I can see this is where the uterosacral ligament is. So I will do that as well. You hold it, please. Thank you very much. Remember, we're going to do two angles, each one separate. So this one here, again, two, and then the small one. You come closer, and you do that, and you can see now you're ready to alternate the hatch. So I go on that side, and I'll do that. Good stuff. Let's cut the short one. Then I'm going to take another bite of that. Yeah, good stuff. And then I'm going to take the needle off. So we're going to start from Lena side, the other angle. So angle by angle. So now you can see now. Traumatic grasp, please. Traumatic grasp. Good. Then can I have another stitch, please? Needle holder, please. Needle holder, please. Good stuff. Thank you very much. And scissor, please. I know. You're a star. You've done great. So now what we're going to do is do that. You'll come close to the needle here. And needle will cut between the two. Yeah, good stuff. Leave this now. Then we'll get the other needle. Other needle, please. Can I give this to you? Cut, please. Then we're going to stitch exactly the same like last time. And traumatic grasp in your hand, please. We'll go in. See smiley positions. Lena will place it, and then I'm going to adjust it, go to the middle. You got now what we call it no depth perception problem. And it's stitched. Traumatic grasp, please. You're going to see the vaginal edge. And this is the other edge. See that here? So this is the other edge. I go from like that. stuff. And this is other edge here. Good. I need to hold it, please. And after that, you can even do what I prefer normally to do, which is to place the needle like that and get these two together and then two together. Like that. Then you can place, see where the uterosacral and take a good bite of the uterosacral. Good stuff. All right. Then tie that. Good, and cut the short one, please. Yeah, this one. Good. Perfect, and then I'm gonna take a few bites and tighten the first one, and this will be the culvotomy. Traumatic please. You can see I alternate traumatic grasper to allow me to grasp the edge very well, so I can see what I'm stitching. So this is the, again, the edge here, and the edge here. You can see this very well. The peritoneum as well. You'll hold it, please. So one more bite. Traumatic grasper, please. You'll hold it, please. I think this is the, is it? That's fine. Good, so get that, and we'll take, maybe we lock it or something. Obviously, yeah, we didn't, so that's fine. So be sure that we do that well, and then we'll proceed with the final bite, and then tie both of them at the end. Traumatic grasper again, please. Good, and grasper again, please. And then we'll tie everything. To keep it transverse, one, another one, very short, but you can manage, and get this one here, and then you do that, come closer, do that, and then finally do the final hitch, again transverse, and that, good. And then, we'll cut both of them. Then we're gonna get suction irrigations. So the needle is out. So we'll irrigate that. Fluid on, guys, please. Fluid on. So what we're going to do now is we need to drop the pressure down to 5. We call this closure pressure, which is allowing us to see if there is any sort of oozing. So when I suck, I will suck till I have the pressure down on the screen comes to less than 5. And when it is the case, you go in with the camera, check your pedicles. So it's now 6 and going now to 5. to see if there's any oozing anywhere, you deal with it. So this is what we call closure pressure. Then we're going to do now the tab lock. Back to normal, please. Back to 12. Then we're going to do tab lock. For tab lock, can have back to 12. So for the tab lock, we need to do the following. We need to go midway between the SI and costal margins. You can see the peritoneum change from that to that. Now, this is the transversus abdominis muscle and the peritoneum underneath it. So what we're going to do now is, needle, please. Yeah. Vertical till you see the needle passing through the muscle. Where are you? One second. You need to figure out where you are first. 1 second. 1 second. Lina. So here, and this is vertical here. Yeah. So Lina will get the needle so you can see. Don't go into the peritoneum. Between the muscle, and that's fine. Aspirate and then inject the rest. We show this on the other side as well. So 20 on that side. And then we'll do 20 on the other side. Have the other one, please. So other side again the same. This is the transverse muscle. You can easily see it. And the peritoneum over it, midway between the costal margins, and you can see clearly the muscles and the peritoneum. So I go. Good. So I go till I am actually touching. That's right. Take your time. All right. Can we clean the lens? All right. So till I actually become, see, I'm touching the peritoneum now. Then aspirate, and then you inject the whole of it. You can see it spreading between the peritoneum and the muscles to give the required local aesthetics. Perfect. So we are now finished. So what we're going to do now is final look. Because it was a big vaginal test, so we might put a camera inside the bladder to be certain that your bladder is fine. All right, so we're going to just go then. So guys off, please. Remember what I said about pneumatic maneuvering, which is after you finish, you exfiltrate the gas. Gas off. And then be sure that all the gas comes out. And once you have all the gas out, you ask the anesthetist to do 5 manual buffs. Can we have 5 manual, please? Yeah. While you are doing breathing just below the costal margins, which allow all the gas trapped underneath diaphragm to go through the import. And this is called pneumatic maneuvering. And this will reduce significantly the postoperative pain. Perfect. Yes.
Doctor, please, can we see the sides of the tap lock from outside, please?
And here you will come to discuss in a second. Just, let us finish this off. That's fine. Perfect. So now Lena will finish everything off. We're going to do cystoscopy. So what I'm going to suggest now, can we switch it to the office computer so we can have a little bit of discussion about the surgery? Can I give this to you now?
بس الحين عشان كلمت خديجه لان خديجه اللي تسوي الاستفتاء ماشي تحكي شفتيها غيرت ولا لسه؟ والله دحين اوريك لو قلت لي كنت
Can you hear me, guys?
Yes, Professor Afifi.
All right, so let us go through quickly about some of the stuff which I like to remind you. So we agreed about how you can do safe.
Do you like to open your camera, Professor Afifi?
Yes, absolutely. All right, can you see me now? Can you
Yes,
see?
sir.
So let us go through some of the bits which I like you to take from that surgery. So the close entry, we've seen actually how to do the incision. The umbilical is vertical from the bit to the skin. You do it like about 1 centimeter or even millimeter. You hold the varus needle as we agreed, 4 centimeter from the tip, and you insert it vertically, and you get 2 click or 4 centimeter in. You check the entry pressure, and then you insufflate till you achieve.
Doctor, please, slowly. Sorry.
Till you achieve the 25 millimeter mercury, and then you do the 2-hand technique to get it to carry in. You check the side of entry. Positioning, we agreed that actuation has to stay flat till you check the side of entry from the optics. We agreed that the legs needs to be slightly with hip flexions, and you need to keep the arm on the side, not over the chest, because this allows you to move the camera easily. All of the ancillary boards, which is second, third, and fourth, has to be done under vision. And it's very important to keep them under vision to avoid any injury, because any injury from any second or third or fourth board is inexcusable.
Professor Afifi, can you please put the mic away from the speaker?
There's no mic.
Sorry, doctor. Now you have 2 access to the Zoom on the same time. Because of this, there is echo.
I see. So let me ask them to switch.
Yeah, because you have 2 access, so the echo is going on. Okay.
Yeah, maybe my phone. Sorry. So it is. We unmute every bit we have. Can you hear me well now?
Yes, Professor. Yes.
All right. Good.
Yes, Professor.
So we agreed on the positioning of the patient, and indeed on the diathermy pedals and the setting of diathermy. You noticed that I didn't change much of the instrument. Most of the time I have my phone on my left-hand side, then either the scissor or the thunderbeat or on the middle port, and Lena or the assistant got grasper on the right-hand side, which is helping. All surgery, you might end up with problem. So there was a significant perforations, which was trying, of course, she was stressed because of the link, etc. That's fine, and this can happen even without stress, that you might end up with problem. When you have a problem, first you need to come down and you need to address it, and address it, by the way, which allow you to know how to do it in a safe way. So we know that there was a vaginal tear because she tried through the vagina. There is an ablation, so there is significant interuterine adhesions. So most likely she did before the cervix into the vaginal wall, and this was obvious when we removed the uterus, that there was a significant tear vaginally extended beyond it, and this was bleeding. So again, all what you need is just evaluate the complication when it happens, address how you can deal with it safely, and by the way, deal with it safely mean you might decide to change the access, you might decide to pause, you might decide to get help. Depends on exactly what sort of complications you have. Laparoscopic surgery is successful when you are actually trying to enjoy it, because it's very enjoyable surgery, because you can't have exposure as good as in laparoscopy anywhere. I mean, much better exposure.
You've seen that we check the ureters, we set the ureters far away. If not, then we have to lateralize the ureter by retroperitoneal axis. And when you do that, it's not difficult, it's quite easy as well. But at all time, we are not trying to speed up. Actually, we are trying to do things slower as we can. What I always do, even if you are not with me, talk while I'm doing surgery, like talk to my assistant, pretending that I'm teaching her, but actually it's not for the purpose of teaching, it's for the purpose of me doing the surgery in the right way. So this is the bladder, we're going to reflect the bladder, see this is the bladder, this is the uterine, we need to scrutinize the uterine. When you do that, you realize that you are following the book instructions, because actually you're trying to do that while you're teaching, and this will reduce the human errors of being out of the box, trying to do something silly. You've seen very interesting finding, which is actually, I don't think many seen it before, which is the torted tube. So this lady had normal looking ovary. On the scan, they haven't seen this necrotic tube because actually nobody is bothering to check the blood supply to the tube. She had sterilizations, and bit of the sterilization, because she had more than one clip, has been dislodged the tube, like cut the tube, and the cut part of the tube torted around itself, become necrotic, and this is why she got this pain on the right-hand side. So all the time we assume it is endometriosis recurrency, might be adenomyosis, it might be post-ablation pain, but it is mainly from this necrotic tube. But of course, she used to have the pain before the sterilization as well, but not as bad. So in that case, it might be that mix of reason of pain. But anyway, we left her left ovary, which means that she will end up having more or less average age of menopause, and also take the uterus out and the tubes, which will be helpful as well from the point of the bleeding and pain. So let me take questions first, and then I will go back to talk about something else. So if we have the 10 minutes for your questions, so it is now, if we carry on for 10 minutes for question, and then we'll have 10 minutes for break, and then we'll come back to each other again for the second thing. Questions?
Doctor, please, regarding the uterine manipulator, okay, which you used already with the cup. This is the first time for me to see this one with the cup, and how you are closing also the vaginal vault after you remove the uterus. And the number two, I need a clear anatomy for the ureter. How I can see the ureter easy, and what is the external point for the tap lock? This is my question. The first one about the uterine manipulator.
Yeah, so it's called V-Care. It is disposable one. It has a colpotomy cup, the green one that you've seen stretching the fornices. As I said to you, you insert as you've seen as well, you inserted the manipulator inside the uterus, inflate the balloon, and then normally it will stay in. Then you advance the colpotomy cup, followed by the retaining or the retention cup. And it is very practical, it is very cheap, and it's very available. So there are many companies now producing it. So it used to be one company, and in sterling in UK it cost about £22, something like that. So it's not very expensive. Of course, back home you might end up using it forever, and it's quite cheap. You said that how I did close the vaginal vault. You've seen me closing the vaginal vault.
Yeah.
So so what I always do is, I mean, again, if you are not mastering suturing, you can use barbed stitch like Stratifix or V-Lock, which doesn't need a lot of tying knots. And again, you do it under vision, you do the angle, and then as you normally do with open surgery, I like to do the angle and then the uterosical ligament, modified McCall, which provides support in the vaginal vault. So I do angle by angle and then carrying on in the middle and then closing it. And by the way,
I mean how we are closing it from the vagina. What you are putting inside the vagina to keep the flow inside, not to be yeah.
Put one swab in a glove, and then tie it, and then you put the swab with the glove inside the vagina. This will give seal, preventing the gas to go out. You've seen this bulging balloon. This was like actually a glove with a swab in it.
Okay.
So you put a glove inside a glove and then tie the glove and then put the glove with the swab in the vagina. So this will prevent the gas leakage, allowing you to suture it.
Okay.
The ureter transperitoneally, you go to the IB ligament, 1 centimeter from the IB ligament, right or left, you will see the ureter flicking, and then you follow the peristalsis down to see exactly how far it is from where you're going to be using diathermy. If you have more than ½ centimeter distance between that and your pedicles, then you don't have to do extraperitoneal reflections. Like in that case, we've seen it, it is far away, gone down, it's even beyond the cup, so it is away from the uterine, away from the IB ligaments, away from the tubovan ligaments. In that case, you don't have to do extraperitoneal examination. But say that it is not, there's adhesion or something like that. Then you open the round ligament on the other side to go retroperitoneally, and then you explore from the psoas muscle down to the IB ligaments to see the ureter clearly, and from that point start lateralizing the ureters to be allowing you to proceed with the uterine and the rest of the surgery safely. Again, it is not complicated, it is quite simple. All what you need is just be gentle and do your dissections as we always asking you to do. Use your two-hand technique, use your camera handling right, allowing you to see well, dissect well, and dissect safe. And guess what? If there is any small bleed, as you've seen it frequently during surgery, you place the two sides of the insert to the bipolar on the side to control the bleeding, which allow you to proceed. Simple.
Shall I make it?
Prayer, please. Prayer.
Make it so you can see everybody.
Doctor, I want to ask about the pressure. When you first inflation of the pressure during breast needle, when you put the breast needle, you start inflation of the intra-abdominal. Up to which level we will have to put
25. It has to be 20, 25. This is called insufflation pressure. And the reason why we said this is the safe pressure is when you do that, even with 3 kilogram force you can apply over the umbilicus when you are inserting the car, the gas bubbles underneath will be about 4 centimeter, but not the 4 centimeter existing, which will prevent any risk of vascular injury.
Okay, thank you.
About the tap lock pointing from outside.
Yes. So from outside, midway between ASI, between the anterior superior spine and the costal margin. And from inside, you see the transverse muscles and the peritoneum overlying it. And then what you need, you go midway, as we said, insert your needle vertically, you check the needle. Once it is over the peritoneum, aspirate and then inject 20.25%, which spread between the muscle and between the peritoneum to provide enough local anesthetics.
Thank you very much.
بروفيسور ممكن أسأل سؤال؟ حضرتك عملت اوفريكتومي ليفت اوفريكتومي بالرغم من انه حضرتك discovered الكوز اوف بين على الليفت سايد ما هواش محتاج اوفريكتومي على الليفت سايد. انا عارفه انه حضرتك واخد طبعا كونسنت، بس once you discovered that ان الكونسنت في حاجه اختلفت فحضرتك شلته ليه؟
That's actually a very good question, because finding a cause, it doesn't mean it is a cause. So we've seen bit of the tube blackish color or having color changes suggestive torsion and ischemia, all right? I believe that it is a significant part of the pain problem, but also I cannot dismiss that this could be part of the problem, particularly that she used to have the pain as well before the sterilizations. So the meaning of that is sterilization and what happened in the tube might exaggerate her pain. So if you decide to take a unilateral decision that I'm going to leave the ovary behind because I believe now that there's another cause for the pain, and if the pain didn't go, the patients will come back and actually causing out a problem because the consent after detailed counseling agreeing about removal of the right ovary. Do you agree? And because we are leaving one ovary behind, and you know the evidence when you do unilateral oophorectomy that there is no significant increase in risk of premature menopause, and actually the difference in the age of the menopause is about 1 year less, so you are not significantly disturbing the hormonal status or the timing of the menopause by removing one of the two ovaries. But it's a good question, well done.
Doctor, please. I have one question.
كمل بس السؤال التاني وحضرتك ممكن تدخلي. لو احنا في ايجيبت مش عندنا الكاب اللي بتتحط في الفورنيس في around the cervix، ايه البديل؟ ايه ممكن استخدمه بديل؟
كنا زي ما نحط صواب، وفي دلوقتي حاجات كمان ريوز. What I'm saying to you is البتاع ده في مصر موجود، بس الناس بيستخدموه طبعا ريوزبل. هو ثمنه اساسا يعني it is very cheap instrument. بس it's very useful. بس طبعا في بدائل له، يعني في كولبوتومي تيوب موجوده برضه اللي هو اللي هي الاوريجينال one which we used to use before having all of these manipulators. ستورز عندهم reusable 3 manipulators with cup، ولمبس عندهم 2 manipulators with cup. يعني في الماركت a lot of manipulators having colpotomy cup which allowing spectrum to be done safe. ميزه ده انه ده واللي زيه يعني انه اكستريملي تشيب، مفيش حاجه ارخص من كده في العمليات خالص، يعني ارخص حاجه موجوده في الشغل بتاعنا. فيعني and it's very helpful and very easy to insert. يعني المره دي بس عشان اليوترس كمشكله، انا normally it's quite easy to insert and quite safe to insert as well.
Doctor, there is I saw before also total abdominal hysterectomy done after removal of the uterus through the vagina. Start suturing as usual from below, from the vagina, not through the laparoscope. So what is the difference? What is the difference? Is there any difference between this and that?
بص عليك يعني في ديبيت هو السوتشر من تحت والسوتشر من فوق. Depends on your experience and the way you like. Of course, if you master suturing, it's better to do it from the top. But if you're struggling with laparoscopic suturing, it's better to do it from the bottom. Actually, it is good. So if you're a good vaginal surgeon, it is easier. So whatever you feel easy with. But my point with that is, it is very important to learn suturing because this will provide you options and make your surgery safer. There's a bleeder. And instead of like carry on burning and doing a lot of dithermy, you can use suturing, which allow you to get sorted. So all what I'm saying to you is, you need to practice on suturing. But at the end of the day, when you do hysterectomy, you can do it vaginal suturing or also suturing based on your choice.
Okay, thank you.
More questions?
Doctor, regarding the clips, this patient we have done clips bilateral for hair to close the tubes. Actually, why we are using clips? Why we are not simply cutting as we are doing in sterilization without clips? So we'll avoid the complication of having torsion or have chronic pain or having such a complication.
Actually, that's a very good question. First of all, clips is the safest method of sterilization. Because in the traditional one, when you cut part of the tube, you might compromising the blood supply or the nervations across the tube and causing post-sterilization pain, which existing in 10% of cases. Let me tell برضه اخوانا اللي برضه في ناس فاتحين الكاميرا وفي اولادهم في الصوره، فعشان بس في تيوب وريكوردنج ماي سجشن بليز عشان ما تزعلوش، بس بعد كده ما تلاقوا الصور فيها حاجه، اللي فاتح الكاميرا على حاجه مش عليه هو يقفل احسن. ما علينا.
So you think that modified memory which we are using? Yes.
جاي. فالكليبس is a safest way from that sense. It has less post-sterilization pain than the other ways. From the point of reversal, لو انتوا عارفين طبعا في كل حاجه الsterilization في regret between 4 and 20%. To do reversal after clips is much easier because it maintains good length of the tube in a healthy situation, which allowing you to do reanastomosis. And it's much easier. So you can do it, and now there's a disposable clip pliers, which can be like much easier. So answering the question is why? Because it is safer and easier. This case is actually can be published because actually it is, I haven't seen torsion following clips. This is the first time I've seen actually total tube following clips application. So we've seen something very different today. So you cannot actually.
Doctor, is the torsion related to the segment which we have left? Like when we are applying the clips, maybe the segment was long enough to cause torsion and congestion?
لا التورشن يا دكتوره لما بتعملي اي sterilizations ستيتش او اي حاجه، المفروض الحته البلوكد اوف التيوب نورمالي بتسيبريت، يعني بتلاقي نفس في الاخر تيجي تشوف العيان بعد كام سنه كده تلاقي حته من التيوب لوحدها كده واقعه، يعني التو سايد اوف التيوب they are not connected. In that case it seems ان الجزء اللي هو البروكسيمال اوف ذا تيوب اللي عمل الكليبس مش عارفين كده استخدم more than one clip on the side. فبقى في كليب اتاتشد وفي كليب تاني more distal, and what happened is this distal part of the clip become a leading site of separated tube which twisted the tube causing the torsion and causing a change colors. طبعا احنا بنقول دايما ما نحطش اكتر من one clip except if you are not certain ان الكليب is in the right position. Any more questions?
Thank you. Thank you.
Thank you, doctor. Thank you very much. Really, it is a very nice presentation for us. Very exciting to see this laparoscopy. Thank you from Sudan, Dr. Ampinan.
طيب لما ما فيش اي question تاني بقى احنا وجانا have a break for 10 minutes.
Can I ask a question?
اتفضل يا باشا.
If we have a large fibroid uterus, how can we get it from the stump if the stump is small?
Stump يعني ايه stump؟
Yeah, from the stump, the uterus, get the uterus out.
لو قصدك بقى لو شلت اليوترس عايز تخرجه بره في تو اوبشن، لما تعمل ميكانيكال فاجينا مورسيليشنز لما تحط مورسيليتور فروم ذا توب. فلو انت عايز، لو انت مثلا عندك big fibroids and you know that when you remove the uterus and you cannot remove the vagina easily, you can cut it from the vagina يعني morcellate mechanically, or you can use electric morcellator from the top to morcellate the uterus to retrieve it out.
Thank you.
سؤال بعد اذنك يا دكتور.
اتفضل.
This set we have bipolar and unipolar are available.
Yes.
So when to use unipolar and when to use bipolar and what is the difference?
لو انت خدت بالك البايبولار I use it for hemostasis and you can use it for vessel sealing. المونوبولار I use it only for clean cut, for clean diathermic cut. يعني حتى لما تيجي تبص السيتنج مش هتلاقي عندي، ما بتلاقيش بستخدم الكواج مونوبولار دايثيرميك، استخدم بس الكاتنج مونوبولار دايثيرميك. فام يوزنج المونوبولار for clean cut diathermic cut and I'm using the bipolar for the rest of the hemostasis and vessel sealing. طبعا انتوا شفتوا الثاندر بيت ده combination of harmonic and bipolar which allow you to seal and cut. برضه الحاجات دي لما تيجي تستخدمها لازم تستخدمها carefully because if you are not familiar with it هتعمل more bleeding from it وهتعمل more damage from it. And this is why the basic of surgery has to be followed irrespective of the instrument that you are using.
شكرا.
جميل. الساعة دلوقتي يا اخوانا 11:30 ان شاء الله نرجع لبعضنا تاني in 10 minutes، فكل واحد عايز يعمل حاجة يعملها عشان نتكلم على الحالة الثانية اللي ان شاء الله تبقى more useful لانها غالبا حالة infertility plus pain which will be like of more interesting.
شكرا.
Thank you very much, doctor. Thank you.
بصي ما كنت خلص عليك كتير عشان هبدا معاك فعلا. اتصال رجع بدري ما يصحش. قلت له روح قال لك سمعت خد. فزعت. معاك بس ساعه 3 كده. ماشي اكيد انا حاجه بس ماشي بس مين؟ الكلام؟ ساعة؟ ساعة؟ لا غير طبيعي. ايوه معروف. بصراحة ايوه.
So, is everybody back. So, Islam. Can we, somebody is making a lot of noise, I don't know who is here, but can we make a start?
خلوهم يعملوا ميوت اول يا دكتور قبل
Can
بعد اذنك.
everybody unmute please so we can make a start? يا دكتور يا دكاترة.
We are back, doctor.
Can we unmute? There are a lot of noises on the background. So can we, if everybody unmute, can we open the questioning site, please? I'm not sure exactly. There are some people who cause a lot of noises on the background. It's not me, so let us start. So the next lady is a very interesting story. Can you hear me?
Yes, doctor.
Right. Next lady, she is in her 20s. She had before rupture. She had before rupture appendix, which obviously was very complicated. But we ended up with bladder injury, which is very uncommon, but this is what happened. And following that, she had significant pain. And the imaging suggested that she got, oh my goodness. There are somebody, can please, can please unmute so you end up, yes, shukran. So I'll back again. So the lady coming, she's in her 20s. She had before rupture appendix. They tried to do it laparoscopically and then ended up with bladder injury and bladder repair. However, following that, she got significant pain, and the pain significantly affecting her quality of life. And also, she was trying to conceive and unable to conceive. The imaging suggested that she had hydrosalpinx in one of the tubes. She got religiously a reason why she doesn't want IVF treatment. Some Catholics are very much against the IVF as a fertility treatment. So she is very keen for her to have surgery, aiming to deal with the pain she has, but also to help with the fertility as much as we can. So the expectation is you're expecting a lot of adhesions and scarring from the rupture appendix and from the difficult surgery following it. And we know from the imaging that she got hydrosalpinx as well. So entry, we agreed before that when you are expecting a lot of adhesions into the pelvis, as in that case, it's better to do something else, which is palmar entry. So we're gonna try palmar entry in that case. We agreed that in palmar entry, we go to the mid-clavicular line, one finger below the costal meridian on the left side. This is the traditional or classic palmar entry. And we're expecting to have 3 clicks. If you are using palmar point, it's better to decompress the stomach using nasogastric tube. But actually, we do modification for palmar by placing the needle in the anterior axillary line, which actually allowing that we can proceed without need for nasogastric tube. It is 3 clicks because you go through the 2 layers of muscle and the peritoneum. There is no underneath blood vessel that you're worried about. You use the same entry check, which is the palmar entry points and the entry pressure to confirm that you are inside, which, as we agreed before in the closed umbilical, this is exactly the same. All right. Of course, the expectation is out of adhesions. You can see the principle of dissections when you are dealing with adhesions that you need to address the following. You need to know that you can do blunt and sharp dissection, and it's always advisable to combine the two. Using traction and counter tractions, allowing you to see the right plan of dissections, which will be very helpful. And again, you can use the blunt dissection using either one instrument by opening, closing, or rotating the insert, or by using two instruments against each other, or by using the scissor. And of course, the sharp dissections can be done either by mechanical sharp dissection using the scissor, or diathermy or energy mediated sharp dissections using diathermy or similar energy devices. All right. So you're gonna see a lot of dissection. Now, if the tube is dilated, you know, we mentioned yesterday that it is very important to check in case of distal tubal disease, where actually there's a block at the end of the tube. This can be either obstructive, which means dye doesn't come out. In that case, the tube might be distended, forming hydrosalpinx, which might be mild, moderate, or severe. And we're gonna use this case to explain to you how you do proper assessment of the tube without compromising its integrity. Because some of you are grasping the tube with a grasper, even with a traumatic grasper. I'm gonna show you now the best grasper, which you can use it to grasp the tube without damaging it. I always ask my trainee is to place the grasper on the finger and see exactly how much damage the grasper itself is inflicting on the skin of the finger. And if it is happening with the finger, you're expecting much more will be happening if it is applied to the tube. So let us gently with the case understand and know together how to do proper assessment of the four parts of the tube, which is the corneal end. You see cornea, isthmus, ampulla, and the fimbria. And of course, with the hydrosalpinx, as in that case, we'll need to find out whether the block is prefimbrial, fimbrial, or postfimbrial, whether the hydrosalpinx is mild, moderate, or severe. All right? So this is the case. So let us start first with another round of questions before we go to theater. So again, I repeat, we're going to do pulmonary entry because of the history she had. We're going to do a lot of adhesiolitis, excision of endometriosis, and trying to do salpingotomy or salpingostomy for blocked distal tube. She refused completely to have the tube removed because she's completely against IVF as a principle. So we're not planning to remove the tube. So let me open a round of questions before we go to theater. So if anyone has a questions, we can start answering it.
Yes, doctor, please. Would you tell us about the consent you took from this patient?
The consent, yes. So normally it is very important. When you consent patients, you have to consent about what? About actually the procedure, what you're gonna do. Then about the benefits, what this will help her, and what are the risks and what are the alternatives. So always remember that consenting is actually the procedure itself. You describe it including the surgery and post-surgery part of it, and then the benefit, what the expectations, and then the risk and the alternative. So for that lady, of course, you have to describe that we're going to do laparoscopy, adhesiolysis, excision of endometriosis, and salpingostomy. So the aim is to help improve the pain and also improve fertility potential. Come to the risk now. In laparoscopy with no adding risk, there is a risk of bowel injury. And yesterday we explained that it is 1 in 300. But in that case, because we know there is a lot of adhesions and we know that we're going to do a lot of adhesiolysis, so the risk of injury in her case is 1 to 2%. When injury happens, then you deal with it, and you can deal with it either by laparoscopy or by laparotomy. And when the injury happens significantly, you might decide to do temporary colostomy. So all these patients, we need to discuss with them the risk of bowel injuries, risk of laparotomy, and remote risk of colostomy. We agreed that there is a risk of vascular injury, which is again avoidable, and this is why what we have to mention in the consent form. And indeed, there's a risk of a surgery, risk of infections, risk of bleeding, and risk of clotting. So you outlined the risk of the surgery itself, but also in the procedure, you need to outline the pathway for recovery, which means that the patients understand that she will stay in the hospital, she will go home on the same day, which is a day case surgery, like the hysterectomy first lady, also day case surgery, go home on the same day of the operations. Because what you do with this pneumatic maneuvering and tab lock and low pressures, that the patients will have quick recovery. So she can be in few hours time ready, take the catheter out, once pass you in, by the evening, late night, she can go. Might stay for one night, again, in case, this happening in less than 10% of cases, but most of them are day case surgery. Then you have to identify to her what she's gonna have after that. So most likely she will need 10 days to 2 weeks for recovery from the point of driving or physical activities. So she needs to be off work for 10 days, in particular the work including physical work, but she can be doing some sort of office work home, like after a week of surgery. So the patient now understands from you that if the surgery is uncomplicated, that she will have about 10 days or 2 weeks for complete recovery, so she can go back to its normal state before. But also she needs to understand, because you are dealing with a very young woman, what sort of scarring she will end up with. So she needs to understand that she will have the 10 millimeter cut in the umbilicus, 3 holes, 5 millimeter each in the bikini line. You can use absorbent stitch, you can use glue, and we recently tried to use more glue for the skin because it's more cosmetic. Privately also you can use, instead of the 10 millimeter board for the camera, you can use 5 because there's now very nice 5 millimeter camera which allows you to do the surgery rightly. But also you need to explain to her that exactly is what the scarring that she will end up having. The stitch is disposable, so she doesn't have to be having the stitch removed. And indeed, you will explain to her before she goes exactly what you've done, but also you're going to follow this up normally after a few weeks to outline exactly what she will have and what expectation she's going to end up with. So this is how to consent patients after detailed counseling. Now, there is a bit which I haven't discussed, which again has to discuss with the patient, which is what will happen when we open the tube up. This is the salpingostomy. We don't know how bad the hydrosalpinx is. You might know from the imaging, but we agreed yesterday that if you got tube, which is less than 1.5 centimeter dilated, with normal locking tubal wall, this is mild hydrosalpinx. When you open the tube up, you restore its function in 80% or more, with expectation of pregnancy 50 to 60%. This is different if the hydrosalpinx is severe, which means the diameter of the tube is more than 3 centimeters. The tubal wall is either very thin or very thick. Then opening the tube will have about 40% restoration of functions and less than 20% possibility of pregnancy. So from that sense, the outcome regarding pregnancy depends on the state of the tube during surgery. And this is why you have to keep this PET to be confirmed at the end. So we say that we can open the tube, which might help to improve your fertility. Having said that, this open tube might block again. This open tube might be a source of ectopic pregnancy. So when you get pregnant, she needs to have a scan as early as possible, because there is a possibility of ectopic pregnancy. Do you agree?
Yeah, thank you so much.
Any more questions?
Doctor, the salpingotomy and salpingostomy, what is the difference between two?
Otomy means opening the tube, ostomy opening of the tube. So if you go to open the tube up to create a new fimbrium or to open the fimbrium, this is what we call salpingostomy. but if you open the tube, say with the managing ectopic pregnancy, so you want the tube to heal, primary intention. So for this opening to close, we call this salpingotomy. So it is otomy if you do the cut with the intention for the cut to heal, ostomy if you do the cut for the intention for the opening to stay.
Okay, thank you. Thank
you. What about preoperative preparation for the patient, doctor? If there is any antibiotic, for how long?
So you
according
see
to
that actually, as you've seen, we always give the antibiotics with inductions because it has to be an hour before the cut. So normally we receive the antibiotics 1 dose on the induction. Bowel prep, there is no evidence that bowel prep makes a difference regarding bowel injuries. Actually, it might make the bowel more distended and the surgery more complicated. This is why we stop now doing bowel prep. Clotting, we normally give them 1 dose of Clexane as, again, prophylactic, except if patients having high risk of clotting, and this is a risk assessment that the patients will have in her pre-op visit, then she might end up having longer anticoagulations. And this will be discussed with the hematologist, but routinely it is only 1 dose. Because patients normally mobilize following gastric surgery quickly, and it is Dacus surgery as I explained to you. Pain relief, so again, because we are having more confidence regarding the postoperative pain, so the patients normally goes with some paracetamol, and again, this is more than enough actually to take them through the first day or so.
And during the operation, if you have something like adhesolysis or now you will deal with the tube, you'd like to cover the patient by antibiotic for 10 days or something.
So the idea of giving routinely postoperative antibiotics is not recommended. Now the patient is in, so we're gonna stop the office talk, and then we're gonna go to theater now. I will remind everybody, whoever hasn't been joining us before, this lady had before rupture appendix, expected to have extensive adhesions. We're going to go pulmonary entry. She's known to have had salpinx as well, so the intention is adhesolysis, excision of endo, and salpingostomy. All right.
Dr. Ali, I want to tell you that if you are using mic, it will be there is some sort of not unclear voice. So if you during operation theater. So if you can use it, only speak loudly without using mic to check, because in the first operation, the sound wasn't that clear. Your voice wasn't clear. مثل الصدى، صار مثل الصدى أثناء الإكسبلانيشن. شكرا جزيلا.
أقول لهم جوه يعملوا، أقول لهم أنتوا قلتي ده بحيث إنهم يظبطوا الموضوع.
شكرا جزيلا، شكرا.
طب سلام.
Good luck. Bye.
دكتور أحمد سيد أحمد لو سمحت اقفل المايك أكثر من مرة صار.
All right, guys. So
ask them to share your screen.
can you share my phone screen, please, to show you the pulmonary entry? Islam.
Yes, Professor Afifi.
Can you share my phone screen, please, first? Dr. Islam?
Yes, sir.
You get ready.
Yes, Professor Afifi. Hello?
Yeah, can you please share Mr. Afifi's
Doctor,
mobile?
we can see you now, but just adjust the telephone, please.
No, sorry, you're looking at the surgical image. Mr. Afifi is trying to show you the surgical sites.
Doctor, yes, we can see you now, but adjust a picture. Adjust the picture.
The host has disabled Mr. Afifi's phone.
Mm.
Can you please enable it?
Please, can you adjust the camera orientation?
What I do? Yes. Oh, that's fine. That's fine. So can you see now? This is the abdomen by the scope view from outside. Can you table up, please? All right, so what we're going to do now is going to show you now, this is the midclavicle line. So if you go for the rear palmar entry, it is one finger from that. I like to go to the anterior axial line. So this is one, costal margin, and you do 5 millimeter cut. And then we're going to do the needle. Again, we're expecting vertical, three clicks, and then you check.
Please adjust the screen, not clear.
And then you connect the gas and see the pressure.
Please adjust the screen, it is not clear.
Gas on, please.
Once again, please, Dr. Yusri.
Good. So the pressure is 15, which is a little bit high. So we need to be sure that we are in. So I withdraw the needle a little bit. It's fine now. So I think we are in now. Good. So we'll carry on with the insufflation. If you agree, as we before, till the pressure is 20, 25. And then we're going to use 5 millimeter trocar to get the 5 millimeter scope to get inside the abdomen and do the initial assessment. You want to do the bipolar and the thunder beat?
الصورة يا فندم مش موجودة يعني صوت بس إنها الصورة مش موجودة.
Get the bipolar and scissor first, and then we'll let you know about the thunder beat. And can we connect the diathermy and make the setting on 50s, please? Again, while we are doing the insufflations, we're getting the final setting, which is getting the diathermy pedals ready, getting the connections right. Good stuff. You're right. Of course, we are blessed having fantastic team, an athletic team, and theater team. So everything, as you can see, is smooth with no problem, apart from the difficult with surgery. Now we are fine. So we're gonna do the board now. 5mm board again, 2 hand, and then you go in, and the same. Good stuff. Now we're gonna get the camera now inside. Have the tube light off, please. Good stuff. Now we're going to get inside to see exactly what's happening. Always check the site of entry. So the entry site is fine. So we're going to ask to have the head down, and then we'll do assessment using the 5mm scope. And you're going to be now seeing a lot of adhesions. And you can see that if I go with that umbilical, can I just clean the lens? Oh, that's very good. Actually, a little bit higher. Put the head up a little bit. The head up a little bit. You're a very good man. You come every day now. He's fantastic. That's why I thank you much. He's very generous. Now you are the best anesthetist ever, so you come every time. You see, guys, there's a lot of omental adhesions. This is where the umbilicus is. This adhesion is. This is the pelvis. You can see, can you move? Yeah. So there is tube here, which looks like hydrosalpinx, yes. Another tube here. So we'll come to this in a second, but we need to standard repeat. So what we're going to do first, we're going to remove these adhesions. You remember, I didn't put the 10mm camera is. I'm going to put another board, exactly the same side. Finger from the SI, check from inside, looks all right. So I'm going to SI, like that. And your finger like that. And this is where the second board is. You check from inside and your side. Good, 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 good. And then we're going to get to now, we need to cut these adhesions which prevent us to put the camera into the umbilicus. Good stuff. So we're going to use for that, and we can have the pressure down to 15. The anesthetist was very cooperative. So you have to be like appreciating that as well. You've seen this port, guys, having a balloon in. This actually very good because it will keep it inside. So instead of like having it in and out, which will make it. You see a lot of adhesion, as you see. So I'm going to free all of that adhesion off. And then I'm going to put the camera in the middle board and the camera here. And this, after that, we're going to go and check the pelvis. Remember now, so my intention now is what? To improve the scene. So when I start, before this is all from the rupture appendix and what they have before. So we're going to cut this. Actually, there's a lot of space on the right-hand side. So we're going to ask actually Lena to put another board here. And this will allow her to produce traction or counter traction for me. Okay, another 5. So under vision, you see, and then stop. Good. Ready? Ready? Thunder read, please. So what I'm going to do now is I'm going to cut these adhesions. You see now, oh gosh. You see that tractions allow you to see exactly where you are. Then you do that. And I'm going to use that here to free move. There's a bleeder here, so I don't leave it. I just control before I go. Bleeder, I control before I go. That's fine. Then we'll come here. Good. You can see now that this adhesion is taking this ligament. So I try to get it from around the ligament. Can I just do that? See? No, this one will for tube surgery. She doesn't want the tube removed. All right. Just for the sake of anatomy, what that is, you see when you go to the midline, this is not, now this is not, you can see there's something like that and something like that. And we need, this is what we call it, the medial umbilical fold. And it is on the both sides. Remember that I am on actually on lateral side, on my left-hand side. The camera is on my left side, that's why you cannot see it clearly now. Once we finish with that, and you can see when she's done that, I can see now where is attached, like that. So I just gently move it like this, and then start doing the adhesion from here.
What are the instruments you are using now, please, Prof?
Bless you. Yep. She had before, as you remember, bladder injuries. So you have to be careful with this bit as well, because this is adhesions which might be attached to the bladder. On this side here now. Yep. Yep. Yeah, it is done. Good. So what we're going to do now is we're going to put the camera in the middle port. So we'll be having a knife, please. Thank you. And I'd like you to show something which, this is the 10 millimeter port going in. You see when you apply pressure, see that? See how close you are now to the pole? Because the pressure now is 14, right? Now we're going to ask, can you put the pressure to 25? You see now when you do the force, you are very close to the blood vessel in the back. Now the pressure will go up. It's 12 now, so it will go up more. And you're going to see when it is 20 or 25, how actually the gas bubbles prevent further. You see that when it is more distended, now it becomes more safer. Still 15, so it will go up a little bit more. Can you close that? Good. All right, so I get in now. I'm going to change the camera now to the 10 millimeter one, which allow us, can I have the pressure down to 15, please, again? So we change now the 10 millimeter, the 5 millimeter camera to the 10 millimeter one. And we're going to go umbilical as normal. Can we clean the lens? Yeah. Can I swap first with balance? Yeah. Thank you, sir. All right. We'll clean it again. All right. Thank you much. Can I have another 5, please? Well, let me try to get this for you. So you see now that what we get with the camera, with the 10 millimeter, then now we see the middle line here. We have a problem with the fogging. Can I fog again, please? Have some warm saline, please, as well.
Can we see the location of the secondary and the third port?
Oh my goodness. All right. So let's see exactly what's happening. Again, this is the medial umbilical ligament, as you see. This is the adhesions. Come here. Hold the camera, please. Good. Can I have Sandra beat? You see now there is a blunt dissection here. So see when you open the Bible like that, you do blunt dissection using one instrument insert. There is a bleeder here, so I can do that first. Bible is not working, guys. Bible is not working. It's working now. Thank you.
المفروض إن في مؤتمر.
Can I have the thunder beat ready, please? So what I'm trying to see is, I'm trying to see exactly, again, nice from dissection, so I can come and free this move from here, and it's nearly there now. Thunder beat. Good stuff. Then you go a little bit further. See here, again, you get bipolar. Bipolar, and you do that. And when you do that, you free the blood attachment to the momentum. And then you go from the top here, and you can see now we see more of this bit now separated. Remember, she had before other injury, and this is why this is all happening. So this is why we need to be careful. Hold the camera, please. And then I can see now the umbilical ligaments and further attachment here, which can be done. Good. And you can see now that we're starting seeing some progress. And now this is the uterus. Here, good. I'm gonna clean the camera for you in a second, guys. Yeah, can you clean the camera? Yeah, one more saline first. Yeah. Huh? Can I have another scope? See, the scope itself is bad. Can I have another scope? Hmm. So you see, it is the scope itself is vague. So we normally have to check the scope before we started. But again, because of everybody's fascinated by the video, so it hasn't been done. Good. See, now we are getting much better now. So actually, the uterus is good. We're going to change the scope now, so hopefully things will be better. Antivert the uterus for me. Better? Yeah, that's fine. suction the gas. And then we're going to go in, hopefully we'll see a better view. So we're going to assess the anatomy. Yep. All right. Suction irrigation, please. Can antifoc again, please? Antifoc. I put some fluid, clean it with the fluid, so hopefully we'll see whether this will make a difference or not. Antifoc again, please. Antifoc. All right, so it seems that most likely there's a bleeder here. Bipolar, please. Yeah, I can see it. Good. Bipolar. Oh. Oh, all right, so. Was it working again, guys? Can I have another bipolar, please? All right, so this is again to be sure that there's no bleeding from the pit. Just drop it now. So you see now what's happening now is, I think we are getting there, Thunderbeat. We're going to need good bipolar, so I will suggest if we have a new one. Yeah. So you see, this is the tube here, and there's plan here. We'll come to it in a second, so let's cut from here first. Good. Bipolar, please. See, it's very friable because it's normally with the rupture appendix and post-inflammatory, you end up having very friable adhesions. Drop it. Good. Perfect. Now we're going to have a knife and another port in the middle. So I work with two hands, because this will allow me to be like more comfortable with the surgery. And then now we'll see what will happen. Good stuff. Good stuff. Can I have bipolar? And give me a scissor, please. So I'll use the bipolar and scissor now to get more adhesive lysis with some tractions and countertractions. Antifa the uterus. So you see now this is omentum. You see this is the tube here. But one of the advantages of laparoscopy is with the magnification, I can see there's a blend here, dissections. So I go like that. I free this as you see, Lena showed me that this is need to free it. Have you got another bipolar, please? See, it is very, very vascular. All right, Thunderbeat, please. See, this is again gently here. So you can see this is, we'll need to find out the anatomy around the tube in a second. And then if you take this away like that. Clean the lens, please. All right, so you can see now, this is the tube here. Have a suction irrigation, please. Right, this, when it's stuck like that, you put some fluid and you wash the camera inside the abdomen and then adjust the focus a little bit. Yes, fine. Good stuff. So now we come here again. momentum, which is from here. This is all from the Arch appendix. And you can see all this for me. Thunder beat, please. So we're going to free this again from where the tube and IB ligament is. Have you got the pipe already? Yes, we can. Ready? Yes, yes. All right, can I give it to you? All right, so suction ligation, please. So what we need to do now is we need to check the tube. Good, suction ligation, please. We need some methylene blue, please. And let me take you through how to normally assist you. Suction ligation, please. Let me clean the cleanse again. Just to focus. All right. Now, this is the tube now. You can see the tube is blocked at the end, so you cannot see fimbria. So we call this fimbria obstruction. You can see even the dimple of the fimbria here. And now, if you come to the tube here, there's a tube. Tube is attached to the ovary, as you can see here. And then a bit of the tube seen underneath with this adhesion, which I don't know. So we're going to inject some dye, and then we're going to use tube holding grasper, hold this for me, to examine the tube. Inject some dye, please. Dye, please, here. So you see now, she is injecting dye into the tube. And you can see, that's fine, that's enough. Start bluing here, so it's blue. Antivert, please. Antivert. Good. So what I'm going to do now is I'm going to first separate this tube as much as I can from the ovary. Now, Lena will get something we call a tube holding grasper, which is the best grasper that we use to hold the tube. See, it holds the tube with less pressure. See, the tube is very much attached here. Now we know this is the tube here. So I freed now the isthmus of the tube from the adhesions, which was encircling it. Now we can see that this is the tube now here. So Lena even can grasp this part of the tube. Go back with the camera a little bit. And now this part of the tube is where it is attached to the ovary. See that? So I'm trying to free it a little bit. Doesn't significantly affect the integrity, but obviously, when we open the tube, we like to see a free flowing of the dye. This is ovary, which is again itself quite stuck to the side of the pelvis. See that? So we need to sort this out in a second. So remember now the ovary is very stuck to the pelvic side. You cannot see actually much of the ovary because obviously maybe that when you do the surgery, it's all affect. You see that? Ovary is stuck. So I'm freeing now the ovary. Suction, please. Yeah. All right. So, yeah. Good. So I'm trying to free the ovary from the ovarian fossa, which was stuck with adhesion, as you can see. That's fine. You can see adhesions again. Now the ovaries start to be freed from the ovarian side wall. See that? So the ovary is completely stuck to the pelvic side wall, including the blood vessel on the side wall. The bleed, you stop the bleed with just the diathermy, bipolar. And then we'll see now what we've done, and how helpful that was. So now we got some more or less, like not like normal ovary, but ovary, fresh ovary of yours. This is a bit of the ovary again attached here. See that? Very badly attached. In spite of that, there was a follicle ovulations. Back of the commented back. So you have seen now more of the ovary than before because we've done more or less freeing it from the side wall of the pelvis. Of course, you might say, all right, it might stuck again. And this is why we need to find ways of preventing the ovary to stuck again. Good. So let's now showing you how to do salpingostomy. So back here of yours. So we'll see this is the tube which is very much dilated. This is moderate hydrosalpinx. It is, so Lena will hold one side of the fimbria like that. May I hook, please? I hold the other side of the fimbria like that. So we stretch that, and you can see with the magnification, you can see the temple. We're going to put the hook, and then we'll do crochet incisions with a Brolin 3/0 stitch, please. So you see now, this is the fimbria. So I'm going to open that. Activate before I touch, and then you go in. Grasp the edge. It's very scary. So you see that even the cilia is damaged a little bit. So what I'm going to do after that is, I'm going to get inside the tube like that. And as you do with the socks, when you clean it, you go in like that. Then you grasp the edge. And then you bring this like that. Oh. Let us do this again. So when you do, so I like to evade a very nice part of the tube because the tube itself is dilated and large. Can I have so you got a little bit relatively healthy part of the cilia of the tube. And we're going to invert now this edge. With a stitch. Good, just see it like that. All right, Pauline, please. So we're going to get first stitch. Yeah, that's fine. Need the holder, please. And other one, please. This is a Proline 3004 stitch, which you do 1 or 2 to hold the fimbria exactly where is it. So this is the design of the tube, if you remember. Serosa, just serosa. And then you go for the edge which you everted, like that. And now we tie it. Gently and slowly. Give this transverse like that. Put this in the middle. You do 1 round, 2 rounds, and so on. And then go the short tail. And again like that. Again gently and slowly. And then you do that to unlock the hitch. And then what we're going to do after that is we cut that, and then we're going to test the tube again to see how easy the die will come out. Lina will cut very short, very short. And this is very fine Proline stitch. Hold a second. Yeah, carry on, I'm talking about the die. Good. Now, can I have the tube holding grasper? So now what we've done is, you see now, when we get to that, if we grasp the tube from here, this is the fimbrial of the tube, the new fimbria now. So we're going to ask my friend to inject some dye. And you see the dye coming out from what looks like not bad fimbria, because we maintain it till the healthy part of ostia and in good relationship with the ovary. You can add more stitches, but actually if it is like that, 1 stitch is holding it enough. There is no point of more, and it looks absolutely fine. Take the needle off. So again, there was a hydrosalpinx. We freed the tube from the surrounding adhesions. This hydrosalpinx was about 2 centimeters dilated. The tube was relatively thinner than normal, so we call this moderate hydrosalpinx, which means that it carries 50% restoration of functions if we open it up, and it carries 20-30% of pregnancy rate. So what we've done is we check the fimbrial dimple, and then we cut the fimbria, then we invert enough of the tube to allow the cilia to come out to create a new fimbria in relationship with the ovary. We check the tube before and after. Let us look now to the other tube. Perfect. So other tube, you can see as well, oh, more, it's the same. Actually here, you can see the tube not only distended, but become so dilated. You see that? Extended significantly away from the fimbria, away from the ovary, sorry. So you can see, of course, if you open the tube in the original fimbrial side, this will make abnormal relationship to the ovary. So what I'm going to do is I'm going to evaluate how much I need to stay in. So I think this will be enough. Lina will have a grasper, and then we cut the tube at this bit here, and then do exactly the same. The tube is more or less freeish on that side. Yeah. Hook, please. So you see that? I think we had enough from that. Hook, please, because we're going to remove the space anyway. A little bit distal. Good. So you see now, because this is a very much distended tube, good grasp of it. Good grasp. Then remove it. Yeah, goes down. So we're going to open that bit here completely. Does that say 150, guys? Send the beat, please. So you're going to see in this side that the tube itself, despite of that, is narrow, and this sign that it is much worse than the other side. Good. You see there is a band here of the tube, which again, kinking this part of the tube. So I'm going to cut this band. Grasp the tube and stretch it, please. Get tube holding grasper. Can I give you the tube holding grasper? Cut the pipe already, please. Now, what I'm going to do now is try to open the tube and do the eversion as we've done before. One of the obstacles that I have with that lady now is this tube is very thickened wool, not like thin wool as the other one. So, yeah. Why is this one closing? It doesn't close. Hold the camera, please. Perfect, thank you. You can see now here, this is the tube. This is this side of the tube, but you can see there's a kink somewhere. See this kink here? So you see that here? So give us some dye, please. Yes, please. Yes, please. Hold a second. So you can see now, this is the tube here. This is the opening of the tube. This is why there is a kink. Hold this for me. Hook, please. Grasp the opening of the tube well. Good stuff. Now we're going to further opening that bit. You sure this is the opening here? Grasp this. Good stuff. Inject dye. I think it's not that as well. You're injecting? Yeah, it is. Yeah, so you're right. Good. So let me open that further. Good stuff. That's fine. Now, can I go in your place? Thank you. Now I'm going to invert this edge again. This one has a lower potential than the other one, so I'm not going to spend more time in it, about opening it and inverting it. Go in. Good. I cannot see well, so I'm not sure exactly what the problem. Good. So let us try again. Again, what you need with the tubal surgery to be patient. So don't lose your patience. This is very important. Good. It's a very thick tube, and this way it doesn't come easily. But try again. If not, we're going to invert the edge and leave it. See, that's, let us try to invert this edge and leave it. Have you got a mailing grasper? No, let me try this one, but there's not this one. Anyway, that's fine. Let's try this one. That's better. And stitch again, please. That's longer, shorter than that, yeah. Then we get the needle in, the same, needle holder, please. We'll take one stitch again, keeping the inverted edge as it's supposed to be. So this is the needle here. If you come here, good. Can somebody answer my phone, please? Good. We'll do one reverse stitch. We'll do more reversion in a second, because actually it's done. Good, and cut please, short. Cut the other grasper again, please. Let's leave this for now for a second. Yep, the other grasper, please. No, the other one. Yeah. Good. And now cut these. Good. Now give us some dye, please. Good. So you can see now, where's the needle? Yeah, can I have it again? All right, so get section irrigation now and see exactly what's happening. Section irrigation, please. So we've done now bilateral salpingostomy, with more promising salpingostomy to the right than to the left. Both ovaries look small in size, but also quite stuck to the pelvic side, all free. This side still stuck, but both tubes are in alignment with, this is what, grasper, please. So I think now what we've done is we've done adhesiolysis, we freed the tube and other grasper, freed tube and ovary. All right, there was bilateral hydrosalpinx, moderate on the right. No. It's quite big, so we're going to get it. If you got big specimen like that, you can go from the middle port like that. Of course, you can get a bag, but also if you don't want to get a bag, just get that like that, and then grasp it. Hold the camera. Grasp it well, and bring it now toward the middle port like that, the 10mm one, and try to push it in. If not, get a bag or get the 5mm at the end. And so we've done now. So we've done adhesiolysis. We've done salpingostomy. What we're going to do, we're going to have a 5mm scope again and remove this part of the tube out. And then we're going to do tap lock. Can I leave it to you? Just do tap lock. And the pneumatic maneuvering. I'm going to move to the office to take a few questions while Lena finishing this off. Can I give you?
So can we move back to Islam to the office, please?
Yes, sir.
All right. So what you've seen, guys. So first, when you have patients with extensive or possibility of extensive adhesions because of the history she had, then of course it is recommended to go for pulmonary entry. And you've seen how easy pulmonary entry is. It's always, nearly always successful. You don't have to decompress the stomach if you are going to the anterior axial line, which is our modifications. When you go in, you stay with the camera because you need to free the adhesions, which is related to the umbilicus part, to the umbilical part. And when you do that, then you start bit by bit getting the right views. Of course, with that lady, there was always problem with the view. We changed the camera because the camera wasn't right. It was vague. Done irrigation sections, but we need to have certainly good view before proceeding. We've done removed the omental adhesions. We freed the tubes, and the ovary was quite stuck to the pelvic side wall. We tried to free as well the ovary on the right side from the pelvic side wall. Both ovary look small in size, which can give concern about reserve. With understanding that she's in her 20s, she's quite youngish patient. And both tubes having hydrocervix with, again, femoral end block. And as you can see, it was moderate hydrocervix on the right and severe hydrocervix on the left. Of course, if she is willing to go for IVF, you do salpingectomy. But if she has a problem with IVF, if it is mild hydrocervix, even with IVF, better to do salpingostomy. But with that one, half-half. So what we've done is free the tube. We've done the fimbriostomy or new salpingostomy. Then we invert the edge, and with one stitch of fine Purine stitch, we maintain the eversion by placing serosa to serosa stitch. Of course, with the tube, you adjust as well the opening of the tube so it can come close to the ovary, so you have good tube ovarian access, which allow better opportunity from the point of the fertility issues. The other tube was actually the tube not only distended, but also elongated. So it is far away from the ovaries for the point of access. And this is why we've done distal salpingectomy.
نعم يا قمر.
في عدة تليفون فوق على السرح مو
طب هي فين؟ هاتيها لي يا ابو.
تمام. We remove the distal part of the tube and then, of course, adjust the edge by again inverting the edge and placing the stitch. What we're going to say to the patients regarding her fertility potential, we're going to say that she got about 20% chance to conceive naturally, providing that she got good reserve in the ovary. Simply because it is promising the salpingostomy on the right side, less promising on the left side. So, any questions?
Doctor, please, thank you very much for the steps of the operation. And I'd like to ask about the adhesolysis. After the adhesolysis, can we put something to prevent the readhesion once more, especially at the site of the ovary? And regarding this eversion of the tubal end, this will prevent the adhesion of the tubes again. That's all.
So the version of the edge, because actually if you don't, you've seen it, when actually before the stitch, if you leave it, it will go again, which means it carries risk of reclose, which is actually existing in more than 60%. But when you do the stitch like that, it will prevent the...
لسه شوية ولا ايه؟ لسه ما خلصتش؟
خلص. بيقولوا لي ما بيجيبش ارقام ومش عارف ايه ومش عارف.
مش مهم يجيب ارقام، المهم يرن ويرد على الناس.
ما هم ساعات بيقول لك الرقم ما بيظهرش ومش عارف يعني.
المشكلة الرقم ما بيظهرش.
طب
رشا تليفونها كده والله، رشا تليفونها كده. تليفون عيال اللي بيرن يرد عليه. معاكم رقم مين؟
Please mute all admin please.
هو اصلا هو في تصليح قد ايه؟
يا جماعه ما ينفعش كده يا اخوانا، في عشان الناس اللي بيتكلموا كلام جايز go to private discussions. Please can you mute your microphone. اللي مش عايز يسال يقفل التليفون بتاعه، عشان بس ساعات بتكونوا بتتكلموا كلام برايفت and we will it will be like not minutes. فاللي عايز يجيب مفتاح، اللي عايز يجيب مقفل، اللي عايز يتكلم مع
they unmute themselves accidentally, Professor Afifi. So I mute them again.
ماشي، بس عشان بس ما يحصلش كلام الناس مش عايز الناس يسمعوه يعني. تمام، بس اللي عايز يسال يفتح التليفون بتاعه ويسال. فاحنا كنا بنرد على الدكتوره تسال سؤالين مهمين جدا. السؤال الاولاني ليه بنعمل ستيتش فور ايفرجن؟ ده to prevent reclosure, which is a high percentage if you didn't. And this is why we recommend to use a proline stitch, 3O or 4O stitch, one stitch or two maximum, aiming to maintain the eversion as it should be. Anti-adhesions, the best anti-adhesive is the best. So as long as you are not leaving bleeding, you're doing irrigation, proper irrigations before you close, then this is the best anti-adhesions. However, currently we have three types of anti-adhesions existing in our markets. We have the spray shield, which is like spray, put it on the surface, where you're gonna try to prevent adhesions. That will cost about 250 per patient. وبعدين في حاجه اسمها هايلا بارير، وده جل، وده be injected into the surface which you try to prevent the adhesion from. That can be used as well endoscopically، وده تقريبا ب 120 جنيه حاجه زي كده. وبعدين اللي هو الاولد فاشن بقى اللي هو كنا بنستخدمه زمان وبيطل دلوقتي based on the recommendation of evidence اللي هو الادابت. فبيزد اون ذات الهايلا بارير سبراي شيلد موجود، والناس اللي عندهم high risk of adhesions we recommend use one of them. Particularly ولما تيجي تعمل histoscopic surgery, if you're going to do anterior and posterior wall where there is a risk of synechia, then of course recommend to use hyala barrier. بس طبعا اهم حاجه to prevent adhesion surgery is the continuous irrigations and good hemostasis, and avoid excessive use of diathermy and excessive use of suturing, because these foreign bodies are the Any more questions?
Thank you for this very nice work and presentation. I want to ask why use Proline sutures in spite of this non-absorbable and may cause pain later on.
Proline, yes, you are right. It is the absorption is very slow, if not in Proline, but it is known to be less adhesogenic. In the old days, it used to be routine in all microsurgical principle using Proline or non-adhesogenic suturing. Now the evidence that Vicryl might have the same adhesogenicity or close adhesogenicity to the Proline, and this is why people sometimes using Vicryl. But if you like talk to any old man, myself or even older than me, you will see that we used to use Proline because there's an assumption that the adhesogenicity of Proline is much less than Vicryl and other stitches.
Thank you. What about the use of drainage in these operations?
ما هو بقى ده الكلام اللي احنا كنا بنتكلم عليه يوم السبت، انك انت if you leave a drain mean that you're worried about bleed, and if you're worried about bleed mean risk of adhesions. You don't have to leave drain. Drain carries risk, carrying risk. So long as there is no need for drain, you have dry service, you've done a closure pressure with low pressure, there's no any oozing. You've done a lot of irrigation and suctions, and that's what Lena will do now. So she is confident that there is no any sort of oozing service anywhere, despite of the extensive adhesolysis that it was done at the beginning. So in that case, there is no need for drain. But if you in surgery need a drain because of oozing, etc., you can use it.
Thank you.
Not the suction drain.
Regarding
never use suction drain.
Excuse me, doctor, regarding the left tube, that when you remove the distal part, it will not affect the fertility because يعني it looks like some embryectomy you did, no?
ده سؤال جميل جدا. حضرتك عارفه طبعا النورمال length of the tube is 10 to 11 centimeter. You need to have at least 7 centimeter of the tube for nearly close to proper functioning. يعني لو انت حتى في السموثس لو انت عندك tubal length which is more than 7 centimeter, this can be functioning well if the end of the tube is functioning. هي العيانه ما كانش عندها healthy fimbria, so the idea that we lost the fimbria, it doesn't compromise the functionality of the tube. But the reason why I decided not to do the artificial opening in the end of the tube, because you're going to end up having tube completely unrelated to the ovary. You end up losing the tube ovarian axis, which definitely compromising the ability of the tube to be functioning.
Okay, doctor, thank you very much.
But with that, I maintain good length of the tube because the tubal length was more than actually 7 centimeters.
Okay, thank you. Good job, doctor. ما شاء الله.
دكتور يسري شكرا على المحاضرة. دكتور يسري بعد إذنك. شكرا. العملية كانت مميزة وحلوة يعني. ما شاء الله عليك. هلا المريضة هاي بعد العملية بدنا نعطيها هوب. She will get pregnant. وإذا بدنا نعمل لها فولو اب ممكن نطلب لها البنجوجرام بعد قد ايه تقريبا؟
So that's a very good question. So what we're going to do with this patient, with others? You know that I give you the prediction of success. I told you that at the end of surgery, because we know how bad the hydrosalpinx was on the right and left, and how likelihood that tube will restore its function and indeed the fertility potential, so we come with a prediction, which is 50% restoration of functions and 20-25% pregnancy rate. So we're going to say to her, this is exactly what I'm expecting. So she can try. There is a reclosure possibility, and this one we've done the aversion to reduce the closure. So there's no point of reassessing the tube except before at least 6 months. For a young patient like that, if she is intending to go for IVF, if this doesn't work, then we'll do the assessment in 6 months. If the tube is still functioning, we'll give it another 6 months. If nothing happening by the end of the year, remove the tube and proceed with IVF. If the patient is above the age of 34, like 35, 38, and so on. So you've got concern about the reserve and the age. So after 6 months, we can, if the patient willing to go for IVF, to go for IVF. طب لو عيانه زي دي بقى اللي هي مش هتروح تعمل IVF، دي الست دي for a religious reason, she will never go for IVF. In that case, of course, there is no point of doing this serpingiogram in 6 months. We'll do it in a year time. She's in her 20, and she will try to conceive. We need to be certain that she's ovulating well, and the sperm test of her husband is fine. And if there's no other thing that need to be fixed, then she can try for at least a year before giving her the conclusions regarding her fertility potential by then.
Thank you, Doctor. Can I ask about the incidence of ectopic pregnancy in this case?
ده سؤال جميل جدا جدا جدا. Now, let me summarize حتى عشان الامتحانات يعني. So, ectopic pregnancy, normal rate of ectopic is 1%. Ectopic pregnancy in IVF is doubling, so it's going to 2-3%. Ectopic pregnancy in previous tubal surgery is 5-fold, go to 5 to 10%. So she needs to know that the risk of ectopic pregnancy when she's pregnant is 5 to 10%. And the meaning of that is, you need to tell her that whenever she is pregnant, she needs to have early scan to exclude possibility of ectopic.
Thank you.
I will repeat again, this is very important to know whether it is IVF or tubal surgery or IVF following tubal surgery, that the risk of ectopic existing and patients need to be aware of that.
It's from 10 to 20%, doctor?
5 to 10%. The risk after IVF and Doctora is 2 to 3%. The risk after tubal surgery is 5 to 10%. تمام؟
ممكن
ممكن اسال سؤال يا دكتور؟
اتفضلي يا فندم.
لو هي تشينج هير مايند وقررت تو جو تو اكسي التيوبس على الوضع ده يتعمل لها سلبنجكتومي؟
Oh, that's a very good question. So على الوضع ده she needs to try first to conceive naturally because there is 20-25% and the IVF will give her 25-30%. Before the IVF, we're gonna scan her. If the tube is still opened, so there is no hydrosalpinx, we know that we remove the tube in case of hydrosalpinx to reduce the risk of the impact of toxic fluid inside the tube on the implantations and embryo transfer. لو ما فيش hydrosalpinx, no need for further action. She can go for IVF. If there is hydrosalpinx, she needs to be counseled for salpingectomy.
شكرا.
Any more questions? جميل. So what we're going to do now, إن شاء الله تروحوا بقى تصلوا تغدوا وإن شاء الله we'll come back in an hour time علشان proceed with the final case of today. اللي عايز يعني يبص على final case. Final case هي حالة more complicated, is known to have quite extensive adhesion and endometriosis, so it is more complicated surgery from the point of endometriosis excisions. She's having what she's having for pain mainly and for less extent fertility. So inshallah we'll see each other again hopefully بإذن الله الساعة عندكم 2 مش كده؟ الساعة كام في مصر؟ الساعة 2 و8 دقايق. إن شاء الله we will come back بإذن الله quarter to يعني ادونا كده 45 minutes for lunch and for praying والكلام ده and then we'll start إن شاء الله the last
دكتور أنا بس عايزة أقول لك يعني ممكن اللكتشر هذه والدiscussion والفيديو can be sent to our group يعني نستفاد من عنده. It was very nice.
It is already available on YouTube.
It will be in the okay. Thank you very much. Thank you.
ماشي يلا.
دكتور دكتور
ايوه
معلش last question ممكن؟
اتفضلي.
طبعا ما فيش expert hands بالطريقه اللي حضرتك اشتغلت بيها، فالعينه دي لو كانت open surgery الريزلتس بتختلف كتير؟
والله لو عملتي اوبن سيرجري المايكرو سيرجيكال برنسبل فاكرين اللي قلت لكم في المحاضره قبل كده ان الريسك اوف ذا adhesions goes up from 0.6% for laparoscopic access to 19% of minimal of the fenestilla incision or transverse incision. I always say when you do surgery, do it in microsurgical way, which means careful handling, delicate handling, proper exposure, good hemostasis. If you do that, your results will be more or less similar or even close. But if you are carrying on doing the surgery the way you do emergency cesarean section, which means cut, and blunt dissections and bleeding everywhere and inadequate handling of the tube, etc., you will end up having very poor success. So it's better not to do it. So when you deal with tube, you have to be certain that you are delicate. You have to be delicate in the way you are handling it. You have to be patient as well. So even if it doesn't go, you don't lose your temper and you start like cutting it aggressively. You need to be like as much as you can, very patient and very gentle. And I think this is the key of success of any infertility surgery. Right.
شكرا.
عيني هذه عملت لها شير سكرين هذه كذا عين يسلك. تمام ما في حسين ما في اي هناك.
الحمد لله متحسنة ان شاء الله.
Can we start? Assalamu alaikum. Assalamu alaikum.
Yes. Alaikum
Alaikum
salam.
salam.
Can we make a start? I cannot hear you well. Can you hear me well?
Yes, very well.
Good. Yes, very well.
Let's start first by taking a few questions for whoever got questions before we start with the third and last one. So any questions first?
ممكن أسأل يا دكتور؟
ها؟
حضرتك آخر سؤال سألته لحضرتك هنعمل سلبنجكتوم للعيان لو العيانة قررت إكزي ولا لا، حضرتك قلت هنري ايفالويت الكونديشن اوف ذا تيوب ولو في هيدروسالبنجز هنعمل سلبنجكتومي. طب الايفالويشن ده هنعمله بهيستروسالبنجوجرام ولا بابسكوبي؟
Scan.
Scan.
It's not about whether there is hydrosalpinx or there is none. If there is, then you need to remove the tube. If there is none, then you can carry on without touching the tube.
Okay.
السلام عليكم.
وعليكم السلام ورحمة الله وبركاته.
Last patient, yeah, doctor. How would this patient ended pregnant without Fimbiria?
How will this patient get pregnant without it?
Fimbiria.
Fimbria. We've done new salpingoscopy. So the outcome of new salpingoscopy, yes. So the outcome of new salpingoscopy, in case of good length of the tube and good normal tubal wall, is actually close to 40% success.
Okay. Thank you.
All right. Any more questions? All right, so before we start, so the next case, she is known to have endometriosis and complex adhesions, and she's for excision of endometriosis. She also having this for the sake of pain. So again, we'll see as before the dissections, the adhesolysis, the excision of endometriosis. Let me take you through the endometriosis quickly, and I know that you had lecture for endometriosis, but let us quickly summarize clear understanding about managing endometriosis, particularly for the infertility patients. We have 4 different types of endometriosis and combination of them. We've got either peritoneal endometriosis, which sometimes we call it superficial disease, with the endometriosis forming either patches, deposits, vesicles on the peritoneal surface, but the depth of the lesion is less than 4 millimeters. And then you've got deep endometriosis or nodular disease, where actually the endometriosis forming a nodule with depth beneath the peritoneum of 4 millimeters or more. Then you've got infiltrative endometriosis, where this endometriosis infiltrating the nearby organs, whether it is rectum, ureter, or bladder, and this is being referred to the organ being infiltrated. So here, bladder endometriosis, ureteric endometriosis, bowel endometriosis. And then you've got cystic endometriosis, where the endometriosis forming a cyst is mainly an ovary, and the cyst, which we call it endometrioma. And then you've got combinations. And of course, endometriosis is associated as well pathologically with adhesion formations. And these adhesions might be minimal, mild, or severe. And of course, in advanced stage where you've got combination of endometriosis and extensive adhesions, then you end up having what we call it obliterative disease, where everything is stuck to everything in the pelvis, picture of frozen pelvis. All right. We'll come now to talk about of course, the 2 common presentation of endometriosis is pain and fertility. And infertility might be related to anatomically to the block of the tube or block of the axis between the tube and ovary, or through these anatomical causes, or it might be affecting the fertilizations by the chemicals which is produced as a result of the inflammatory reactions induced by endometriosis. And indeed, for the cystic endometriosis or endometrioma, there is a possibility of compromising the ovarian reserve. 20% of patients having endometriosis having adenomyosis, which is endometriosis into the muscle layer of the uterus. And before, we used to say that it is unlikely to affect fertility, but as you know now, there's growing evidence suggestive that there's a link as well between adenomyosis and fertility problems. So what we're going to do for patients having endometriosis? Great. First of all, if you are actually treating peritoneal endometriosis or nodular disease or any type of endometriosis, you improve fertility potential. So therefore, any surgery treatment for endometriosis improves fertility potential. But do we need to do surgery for anybody with endometriosis complaining of fertility problems? The answer is no. So if you do diagnostic laparoscopy, you found peritoneal disease for infertility patients, yes, ablate or excise endometriosis, this might improve fertility outcomes continuously. If you have unilateral endometrioma, more than 4 centimeters, yes, excision of endometrioma might improve the spontaneous pregnancy rate. But if you got patient with nodular disease or deep disease or bilateral endometrioma, then you have to think carefully about whether the right thing is to start with surgery or start with IVF. And the bottom line now, conclusion is, for patients who are having complex endometriosis, i.e. deep disease or infiltrative disease, it's better to use IVF as a first-line treatment. And if the IVF is not feasible or is not acceptable, then we'll go for surgery. For patients having bilateral endometrioma, where actually excision of both can carry the risk of compromising the reserve, then we'll assess the accessibility of the ovary for collections. And if the ovaries are accessible for collections, excise the bigger or the endometrioma was suspicious and leave the other one untouched so long as you get good access for collection of the eggs. And you can go through many scenarios where actually patients having peritoneal disease or deep disease or infiltrative disease or combination of all, and always come which of which you need to do. So long as the ovary is accessible for collections and the tubes are not compromised from the point of function by hydrosalpinx, then IVF is the first line. Except in unilateral endometrioma of young patient or peritoneal disease in young patient where surgery is the first line treatment. But surgery is still second line in case of the IVF is not accessible or is not feasible. And in that case, you do the surgery by the right one, which is right excision of the disease. All right. Does this make sense to you guys? Everybody understand now what we do with the endometriosis? Silence. All right. Yes. Any questions about how to manage endometriosis with the fertility? You will definitely in the exam having at least 2 scenarios, including endometriosis patients who are coming to see you in the fertility clinics of different combination, as we mentioned. It's all about the protocol which I outlined, and if you follow that, you will always be safe. All right?
Okay, doctor.
All right.
So with the third patient, I think the patient is now undergoing anesthetics. So again, we're going to go entry. We're going to show you now combinations of the close entry with the optic entry, where we're going to put the camera so the trocar while you are introducing it. So you can see the abdominal wall into layers, which might add a little bit to the safety of the close technique as well, but we follow the same instruction as before. So, again, with that lady, the same both insertions, the same positioning as we agreed, 1 dose of antibiotics as we agreed. It's all exactly the same. So entry pressure, insufflation pressures, maintenance pressures, close-up, it's all the same. So let me go and check what is happening in theaters and I will come back to you.
So doctor, you will not take this one? You will not use the Palmer's point for modified Palmer's point in the entry because suspecting adhesions?
So this lady, there was last laparoscopy she had, there was endometriosis, but there was no extensive adhesion underneath the umbilicus. So I think we're gonna do normal umbilical, but we're gonna add to it optic entry, which means that while we're introducing the trocar, you're gonna see it, you're gonna see the layers of the abdomen itself by introducing the scope inside the trocar itself.
Okay, thank you, Doctor.
Right, thank you. So let me check in theaters and I come back to you for a second. What we're gonna do is the patient, can you hear me? The patient having anesthetic now. So while you are with us, we're gonna quickly give you lectures on the electrosurgery, which will give you some understanding about the electrosurgery use and its others as well. So I will hand it over to Lena so she can, so you're gonna hear now a lecture on electrosurgery.
Yeah,
Good.
fine.
This till we have the patient sleep. And she's in the anesthetic room, so it'll be like 10-15 minutes lecturing instead of you wasting your time. So she's screened.
Yeah, I will. Yeah. So hello, my name is Lena. I'm Mr. Rafifi's registrar, and we'll be talking to you about electrosurgery just until the patient is asleep. She's in the anesthetic room, so probably it will be 5-10 minutes probably. Let me just try and share my screen and open the lecture for you guys. Oh. Sorry, it's not allowing me to share my screen.
Is Dr. Lena as a host?
Yeah. Sorry, I'm not allowed to share my screen. Can I just share the presentation?
We will ask someone for the organizer to make you a host. Mr. Abdulaziz or Dr. Islam.
Yes.
Can you make Dr. Lina as
Can I just share my presentation, please?
a host to?
I'm just trying to share that presentation about electrosurgery.
Yes, sure. Just a minute, please.
Of course. If for any reason I couldn't share it, I can easily record it and send it to Mr. Afifi to send it to everybody, just in case I couldn't share it or we were short of time. Because
it's okay. I think it's okay. We want the lecture, please.
Sorry?
We want the lecture.
Yes,
we want
so
it.
I can send it to all of you once.
Thank you. Thank you very much.
Because I can't share it for now. It takes time and the patient. So if what I'm trying to say, if we run out of time, I can send it to all of you. Or if I couldn't share it for whatever reason, because I can't share it. Oh.
Dr. Islam?
Let me check with Mr. Afifi, see if he can contact them and they allow me to share it. Mr. Afifi trying to rectify the situation so I can share the presentation with you guys. So it might take a few minutes.
We can download it on the website.
Sorry? Sorry, say again?
If you please,
we
wait
can download
for
it
1 minute.
on the website of DIRMAS.
Okay. I'm still trying to share, but it's not working.
You can share now, Dr. Lin.
Okay.
Well,
Can you see it now?
yes.
Can you see
Yes,
my
very
screen?
clear.
Okay, perfect.
لا مش هنا
My name is Lina Anton. I'm an ST7 obstetrician. Sorry? Sorry, can you see it?
Yes, we can
see.
Yeah, perfect. Hospital, and I will be talking to you today about. Hello, my name is Lina Anton. I'm an ST7 obstetrician trainee.
طيب لو لا رجيب شحن موبايلي من وين؟
Safety in operating room, human factors and electrosurgery. So we'll start by discussing why human factors are important. Look at our systematic approach to ensure patient safety in the operating room, and then we'll move on to talk about electrosurgery, and finally our take-home message. So why are human factors important in surgery? It's well known that some incidents of human errors are unavoidable. However, there's some evidence that system can be better designed to prevent or detect errors before a patient is harmed. Most recommendation for our surgical improvement would be to carefully implement.
Sorry, the voice is not clear.
Briefing and training for our doctors in addition to our theatre staff. So adopting a systematic approach to understand surgical errors is based on 3 principles. First is that a human error is unavoidable as it is an inherent aspect of a human behavior. Second, that effective systems allow human errors to cause harm to the patients. And finally, that system can be designed to prevent or detect the human errors before a patient is harmed. So when you're looking in theatre at your setting, all your checklist, all your briefing, debriefing, the WHO checklist that you do in theatre, the timeout, the sign out, ensuring that the patient is the right patient for the procedure, detecting your instrument, your devices, checking your surgical tray, and ensuring that before you start the procedure, the use of your sterile sheets. There are all your safety check measures to ensure safety for your staff and for the patient. Foot pedals as well, they have to be positioned in the right position and placed near your foot so they are easily accessible and placed in the direction as the monitor as well. And if you're using more than 1 foot pedal, keep the same pattern. And so if you used to use the monopolar pedal on the right or the bipolar pedal on the right, just try to sustain the same pattern so you're not confused or you don't accidentally press on the wrong pedal. Got your WHO checklist as well, your sign in, your timeout, and your sign out, which I hope that you're all familiar with. And you've got your pre-operative briefing and debriefing after the procedure. And all these safety checks have been put in place to ensure that we can prevent harm before it happens to the patient. Moving to electrosurgery. What is electrosurgery? It involves using a high-frequency electric current to cut tissue and coagulate bleeding. The flow of electricity, that's a general principle. It requires a complete pathway circuit. The principle of electrosurgery is more relevant in the operating room, where you use an electric surgical generator as a source of electron flow and voltage. And the circuit is composed of the generator, your active electrode, the patient, and the patient return electrode. Pathways to the ground are numerous. It might include the table, your stirrups, your staff members, and equipment. The patient should provide your impedance, producing heat as the electron overcome the impedance. Looking at your frequency spectrum, your standard electric current alternates a frequency of 60 cycles per second. However, your electrosurgical system could function at this frequency, but because current would be transmitted through body tissue at 60 cycles, excessive neuromuscular stimulation and perhaps electrocution would result. So because of nerve and muscle stimulation cease at 100,000 cycles per second, electrosurgery can be performed safely at radio frequencies above 100 kHz. As you can see from the graph, an electrosurgical generator takes 60 cycles current and increases the frequency to over 200,000 cycles per second. And at this frequency, electrosurgery energy can pass through the patient with minimal neuromuscular stimulation and no risk of electrocution. So you've got your monopolar with your active electrode at the surgical site and your return electrode at another site. The monopolar is the most commonly used electrosurgical modality, and this is due to its clinical effectiveness. The patient return electrodes will be placed somewhere on the patient's body, and the current passes through the patient as it completes the circuit from the active electrode to the patient return electrode. Electrosurgical generators are able to produce a variety of electrical waveform, and as waveform changes, so will the corresponding tissue effect. Using a constant waveform like cut, the surgeon will be able to vaporize or cut the tissues, and this kind of waveform produces heat very rapidly. Using an intermittent waveform like coagulation causes the generator to modify the waveform so that the duty cycle is reduced. The interrupted waveform will produce less heat. Instead of tissue vaporization, a coagulation will be produced instead. And you've got your blended current, which is not a mixture of both cutting and coagulation current, but rather a modification of the duty cycle. As you go from blend 1 to blend 3, the duty cycle is progressively reduced. A lower duty cycle produces less heat, and blend 1 is able to vaporize tissue with minimal hemostasis. When you move to blend 3, it's less effective cutting, but has maximum hemostasis. The only variable that determines whether one waveform vaporizes tissue and another produces a coagulation is the rate at which a heat is produced. So high heat produced rapidly causes vaporization. Low heat produced more slowly will create a coagulation effect. And any one of the 5 waveforms can accomplish both tasks. All you have to do is modify the variables, and that will modify the impact it has on the tissues. This is a sample of your waveform that is produced with your cut and with your blend and with your coagulation. And when you modify your waveform and power setting, the impact on the tissue will differ from cutting to blend to coagulation. And the effect, you can see it there on the picture as an example. Moving to bipolar. For the bipolar, you've got your active and return electrodes within the instruments, and your current flow is confined to the tissue between the 2 electrodes. One of the risks that you encounter with using electrosurgery is return electrode site injury. And historically, the most common injury site was skin, because you remember you are using your patient as your return electrode. So for pad site location, you need to choose a well-vascularized muscle mass. And most commonly, we use the thigh to place our pad. And you need to avoid vascular insufficiency areas, avoid irregular body contour or bony prominences. Also, any area that's got hair, you need to avoid to prevent the risk of burns. This is a repeat. So just to emphasize and remind you guys that you have to use a well-vascularized muscle mass and avoid placing it over bony prominence, hairy sites, scar tissues, or excess adipose tissue. And the small to emphasize it further. So advantages of your monopolar: it's easy to use, it's cheaper, and it's best for skin incision. And your disadvantages: it's interference with your pacemaker if the patient's got pacemaker, fire, smoke, excessive amount, especially it's not going to be convenient when you're doing your laparoscopic surgery, and it's significant thermal spread compared to the bipolar. Your bipolar advantages: it's minimal thermal spread compared to the monopolar. It's got good vessel sealing, less smoke. Disadvantages: it takes longer to get the same effect as the monopolar. Now technology's moved forward. You've got your advanced bipolar devices with many devices in the market, your Ligasure, your NSeal, your Thunderbeat, and every industry claim that the instrument that they've got is the best. With the advanced technology, these instruments can provide cutting and coagulation at the same time. And moving forward as well, you've got your ultrasonic devices. With the ultrasonic devices, they provide high degree of precision. So they allow the cutting and as well coagulation. With your advanced bipolar, they cut and coagulate, but it might not be done at the same time. With your ultrasonic devices, they allow this function to be done at the same time, in addition to all the other qualities that you get with the ultrasonic and you might get with some of your advanced bipolar devices in terms of grasping, dissection, tissue cutting, vessel sealing. And as I said, with all companies, every company claims that their device is better than the others. So with your ultrasonic, cut and coag is done at the same time, and it uses ultrasonic vibration instead of electric current. So they claim that they have got less risk of injuries to surrounding structures because of less thermal spread. However, it takes longer time for coagulation, and some of them are not as good as other in terms of hemostasis. Electrosurgical injuries during laparoscopy. So injuries during laparoscopy are not always the surgeon error. It could be to insulation failure, conductive coupling, or capacitive coupling. And we'll talk about each one of them separately. So with your insulation failure, you have to check your instrument before you use. The instrument has got 4 zones. As you can see, you've got your handle, and then you've got your sheath, and you've got then the jaws. And any insulation failure in any aspect of these 4 zones will lead to the circuit, stray circuits, and that will lead to injury. And especially if this part of the instrument was not in your visual field, you will not be able to identify the injury, and the patient will come back to you later with bowel or bladder injury that was not identified intraoperatively. So make sure you check your instruments and make sure when you activate it, it's your operative side, and make sure you can identify any insulation failure before you activate your instrument. Direct coupling occurs when you accidentally activate the generator whilst the active electrode is near another. The secondary instrument will become energized, and this energy will seek a pathway to complete the circuit to the patient return electrode. And this is a potential, it's potentially very risky, and it's
can cause significant patient injury. So make sure when you activate your instrument, they're all under vision. So capacitive coupling. What is capacitive coupling? It's when the electric current is transferred from one conductor, which is the active electrode, through intact insulation into another conductive material, which could be bowel or bladder without any direct contact. And I've tried to find you an example from the internet to see how easily we can cause injury and harm if we activate our instruments, not being aware of the complication and the way electrosurgery works on tissue. And that injury could be on the bowel, bladder, or any it's the instrument that you are comfortable using, that you've been trained to use, that is reliable, efficient, and cost-effective. Main take-home message that I want you to have after this lecture is to make sure that you choose the correct energy source and to be aware of the way it works, its complication before using it. Not understanding the way it works and choosing the right instruments, but understanding the limitations as well and the complications if you use it in the or if you don't understand the way electrosurgery works. Bear in mind the cost factor when using your instrument. So when you do an ectopic pregnancy, you don't need you should be fine using a monopolar scissor or a bipolar instrument, for example, and always be wary of thermal spread. So never activate your instrument if they're not on, and be wary of activating your instrument in close proximity to another instrument because of the injury that you could cause. And finally, an educated preoperative best advocate. Sometimes if the surgeon is stressed, or if the surgeon is doing high complex surgery, which is a position you might be all be going through in a few years' time, theatre staff and your assistant are the ones that are going to ensure the safety of the patient and ensure that the safety of the staff as well throughout your procedure and surgery. So it's very important. For listening, and I'll be happy to take any questions in the afternoon after the practical simulation session.
So guys, what we're going to do now is we're going to move to theater. They are doing now the entry. So we're going to stop from that side and we're going to now start from theater. Is that right?
Okay, Professor Afifi.
Good. All right, guys, can you hear me?
Yes.
Can you hear me?
Yes, yes.
Perfect.
Yes, sir, we can hear you very well.
You're gonna scrub, so just put this mute from scrubbing. What Lena will do is she put the camera into the TrueCar itself, and now she's gonna go through the abdominal wall into layers. So you're gonna see the layers, and she knows with the camera introduction, this is the optic entry, but actually she is inside the abdomen. So she got the gas connected to the TrueCar, and see the tip of the TrueCar now is where the camera is. And the camera is inserted with the TrueCar is still inserted in the cannula. This is the special TrueCar. So now this is the end of it. So she's going to go through the incisions, and you're going to see the layers of the fat, what looks like fat, and then sheath, and then of course peritoneum, and then you are in now. You can see the omentum. So, and when you are in, you stop. So this is the optic entry can be done quickly. And again, still, you check the site of entry. She's taking the TrueCar off. You check that there's no injuries. Now we can put the head down to start the surgery. Can I have the table, the top lights off, please? So, quick reminder, as we always do, we get the diaphragm pedals in place. Can the head down, please? Can we clean the lens? Head down, please. Clean the lens. In a second. And can we have the table up a little bit, please? So we adjust the positions for everybody. And we got some omental adhesion, as you see. That's fine, thank you, sir. And when we move from that omental adhesions, then that's fine, just leave it for now. So you see the uterus works like adenomyotics. And what we're gonna do first is we're gonna put so again, ASI, finger to the SI, and then breast to see from inside. There's no adhesion. This can be site for the second port, 5mm port. And then in the middle, the same. I know there's a band of adhesion. I'm going to sort it out in a second. We'll put this one here. And then, of course, we'll go again with a third. And then we'll do that first. You see, I can see the tip. Screw it gently in. There's a power underneath me. Avoid it. And you're in now. And then the second one, the same. See that? In. Good. And I'm happy. Then the third one, exactly the same. Lena will put it in. We're going to drop the pressure now to 15, or to 12, sorry. And then, of course, because this band of adhesion is obstructing me, so we're going to free it, cut it, so we'll end up having no band of adhesions. So again, then we're going to look to the anatomy of the anterior abdominal wall, which we haven't done in the previous cases, which is very important for you as well from the point of under. Huh? Thank you, sir. I'm not sure exactly what you have to. Thank you. We bombed the balloon. Good. So look at now from the middle line. This is the median umbilical ligament. Then this is called medial umbilical ligament. And then this is called lateral umbilical fold where the inferior-gastric vessel exists. And this is 5 centimeters from the tip. It's again median. This is medial umbilical ligament. This is lateral umbilical fold where the inferior-gastric vessel exists. So this is the anatomy of the anterior abdominal wall that we need to know about it. And then we're going to antivert the uterus. And then we're going to do diagnosis. Gently now, because uterus is very adenomyotic, which means that you might have high risk of perforations. So you see it's bulky uterus. Then we're going to see what's happening. So I always said, be systematically. So can we have the head down a little bit more? This is the maximum you can give to me. Used to be like very generous with that. Who told? You learn now. So there's a sigmoid. You can see there's a bit of sigmoid adhesions here. We're going to come to it in a second. Uterus we start with, which is bulky, soft in consistency, looks like adenomyotics. Then we pouch of Douglas. When you look at the pouch of Douglas, you look at the depth. You need to be sure that it is normal depth. It is normal depth. Then you look from side to side about the endometriosis, starting from the underneath of the uterosical ligament. You can see a little bit of scarring, but there is no active endometriosis seen in the pouch of Douglas. Then you look at the rectal, there's some fluids, but rectal confluence is the rectum here, and there is no pushing or pulling in the rectum anywhere suggestive deeper disease. So it is normal depth, normal peritoneum, with no evidence of nodularity, and indeed a bit of scarring, but no visible lesions, normal rectal configurations. Then I'm going to look to the pelvic side wall. And you can see there's a filming adhesion. You can see that adhesions here, which again is covering a bit of the pelvic side wall, suggestive something gold, could be endo. But there is no visible lesion seen. There's again more adhesion here. See that? And the ovary itself is very much, you see that? Very much again with some filmy adhesion to the side wall, which is again is still existing in this bit here as well. Sigmoid colon is kinked around itself with some adhesion to the side. Tube looks all-rightish, as you see. Corneal end, isthmus, ampulla, and then fimbria. And you can see that fimbria is attached to the ovary, which is existing in 50-20%, but is it healthy attachment or not? It varies. But there's a filmy adhesion as well, which pulling the fimbria up, as you see. If you look to the other side, see corneal end, isthmus, ampulla. You can see this side is healthier. However, you see in the ovary, there is endometrioma. There is a cyst in the ovary, could be endometrioma, hemorrhagic cyst. But again, there is no endometriosis in the pelvic side wall and looks healthier on the other side. Then we have to look at the appendix, if she'd have the appendectomy before. And this is appendix, particularly if she's having the pain. And again, there's some adhesions, but looks like healthy appendix. All right. And then we have to look at the intravesical fold, again from the side to the side. Every time you look from far, this is called panoramic view, then close, and then microscopic. And you can see that you can magnify up to 20 times when you do that laparoscopically. All right, so antivert again. So in summary, there is a bit of adenomyosis, which is significant part of the problem. The ovary is all rightish, but again, there's some query adhesions here, which actually we don't know what is it, but we'll find out. Lena trying to free that as well to figure out exactly this is the adhesion that we talk about. That we will come to in a second. The sigmoid is a little bit attached badly here, so we might decide to free it. Scissor, please. So you see, when you free adhesions, when you do that, so once I do that, you can see what happened there. You can see plan of dissections. You can see a gray area, which is reflecting exactly where you need to go with your scissor. The camera. So you see now I go that, and this is clean cut, clean cut. And then I stop and see again. Then stop and see again. And then of course, go from other directions. You see now when I do that, I start seeing more of the sigmoid which come this way here. You see this bit here which needs to cut. Like that, good stuff. So we cut here. Good, so start separating more of the sigmoid this side here. You can see when you do that, your assistant will hold this for you. And you can see that you need to go this way to free it more. Yep. Back with the camera a little bit. And then when you see that, you can see there's a small band here which needs to be cut to free the sigmoid completely. And this will be it. And then back with the camera. You can see again here, now start seeing more of that. And then start seeing more of that. And then start seeing more of that. And then once you come to this bit here, you can see the small band here that needs to be cut. And this will separate more of the sigmoid. You've done bit. Yeah, focus, please. You're right. Yeah, perfect. So you can see now that this all was attached. You can see a little bit of small bleed, not a bleed, but cavernous bleed. So with the bipora, like that, and that's it. And like that, and that's it. Like that, that's it. So you can see now that we freed actually most of the nexal site come to the sigmoid, and that's it. And when we do that, you can see that actually you can free it more, where if you want to see the ureter after that, you'll be able to see. See that here? Whether we need to do that or not, let's leave it. Because you can see now, this is the ureter moving. This is sigmoid now, and the kink of the sigmoid is already gone now, which was attached. So we got now 3 sigmoids leading to the rectum down easily. Now you can see the tube. And now the tube is a little bit as well kinky with adhesions. So Lena, she's gonna get tube holding grasper. Can I have a hook, please? And she's gonna show you now when she grasps the tube with this nice grasper, band of fine adhesions, which is actually make the tube very kinked. So this one is fine now, but she goes a little bit lateral here. No, gently, gently. So you see now when I do that, you can see that, see again this band of adhesion here, which you see I activate before I touch and just do one touch. And when you do that, you can see more of the tube will be freed. Back with the camera. And then yeah, like that here. Good stuff. You can see here band of adhesions. You can hook it like that. Good. Can I have the tube from my side? Can I have it on my side? So now you can see more of the tube. Go with the camera. See now this small band here. Grasp at Felina, please. Just put the ovary gently like that. Gently. Good stuff. You see again, this is again very fine band adhesions, which if you are not focusing, will end up missing, and this is actually disturbing how the tube is. Bipolar, please. So now we freed the tube apart from the femur end. Small bleed here. You see bipolar on both sides like that, and just sharp activations. And that's it. Good. Now we'll come now to the more distal part. You can see now where it's attached. See that? And I'm going to look from the other side as well to see whether this is healthy or not healthy. I don't think it is healthy. So this makes the fembria completely away again from the ovary. Hook, please. So you're going to free this bit again. Then that's fine, thank you. Good. And then you look at that. And then can I have the bipolar, please? I think it's not working. So let me go in here. So you see now there's a bit, and you can see a gray area here suggestive is where the tube is attached. So what I'm going to do is I'm going to go like that. Can you push the bipolar a little bit further? Push here. No, push it from here. No. All right, that's fine. Good. Can you see that again? No worries, no worries, no worries. Good. You see that here? So let's see. It's not working. Give me this under a bit for a second. Thank you very much. Let me try this again. And the hook again, please. Good. Suction, please. So what we've done now is, leave the ovary, we freed this tube, more or less, including as well freeing also the fembria to be like more mobile for collections. So it is much better in location of the ovary now. Then we're going to look at the adhesions, which we've seen on the side wall of the camera. This is what we talk about. Can have thunder beat. So you see there's few adhesions here. Good. And again here. And sexual ligation, please. That's fine. So because, that's fine, just leave it. it's all about whether it's causing problem or not. I don't think it is. So now we have side wall, which is fine. Cannot feel or see any nodulations suggestive underneath endometriosis, which needs to be treated. Pouch of Douglas is fine. We'll feed this tube and ovary. Get the bipolar, please, for me. On that side, so we've done salpingo lysis and ovariolysis, which, by the way, very effective surgical for the fertility seeking. See that here there is a bit of a bleeding. So just do that. Good stuff. Let's look at the other side now. Good. We'll take a lot of pictures for this lady. Can you see the front of the uterus? So, all right. So now, as I said to you, there's no much. We thought there is a much, but there's no much even. Very important for these type of patients to take a lot of pictures and recording as well. So she will believe what you said to her, that we've done freeing the tube, freeing the ovaries, and freeing the sigmoids. So do that. Then we're going to do some tap block after that. Good. And following that, we'll do pneumatic maneuvering and go. Perfect. Thank you very much. Over to you. Gas off, please. Or give me the. Can we just show again the tab lock from outside? Let us see. From outside, this is the ASI. This is the costal margins. You go midway between that, and then you go from inside. You will see that this bit is exactly where the transverse muscles underneath the peritoneum. So you go vertically with the needle, and all what you need, just pass the transverse muscle and stay on the peritoneum. You are now on the peritoneum, you aspirate and you inject. And you're going to see the local is actually infiltrating the space between the muscles nicely and the peritoneum. You do that on that side, and then you do exactly the same on the other side. Again, midway between the stuff, you got the anatomy of the transverse and peritoneum, and then you do the top lock. Good, yeah, good. So on the peritoneum, and then exactly the same. Perfect. Then we have to stop or reduce the gas to less than 5. This is the closure pressure. Can I leave it to you? Good stuff. Well done. Are you all right with that now? So perfect. Can you hear me? We're back to the office. So any questions? Any questions, guys?
Before any question, really thank you, Dr. Yusri, for this wonderful day. It was a very long one, but we catch a lot of experience throughout the operation. Thank you very much.
Dr. Yusri, I have one question regarding the type of the manipulator which you are using in the diagnostic laparoscopy. You know, we have different type of TRIME manipulator. Some of them is traumatic. Some of them, sometimes I saw it one time, it's causing perforation. Patient was post-menstrual immediately, and I saw the perforation from the manipulator. So even for the diagnostic laparoscopy, I have to use the manipulator, or I can use any other instrument.
So if you are saying that, can you do diagnostic laparoscopy without uterine manipulations? You can, but you will be struggling to do proper assessment of the pouch of Douglas, proper assessment of the pelvic side wall. So from that sense, I mean, I can see what you are saying, but it's very unlikely to perforate for the normal uterine manipulators to cause perforations. Very, very unlikely. And if you do it with vision and with care.
About trauma of the cervix also, when we are holding the cervix. As I told you, we don't have that manipulator, which I have seen with you today. We don't have it. We have another type of manipulator, which is holding the cervix in a traumatic way.
Yeah, but you know this one, the one we are using now. The reusable and disposable. Disposable, one of it is £5.
Yes.
I'm not sure. What I'm saying is, if you don't have it, get it, because it's very cheap, and you can.
It's better for evaluation and assessment, and even for doing the operation is better, yes, than using other instrument to see. Okay, thank you.
Any more questions? So let me first. You know that I showed you the tube holding grasper. When we grasp the tube, you are using this one or Babcock, which means that the pressure mainly applied to the middle cervix, not to the tube itself. Because if you crush the tube with a grasper, whether traumatic or atraumatic, you might end up causing permanent damage to the tube. So it's very important to grasp the tube delicately, and this is why we use Babcock or we use tube holding grasper.
ممكن أسأل حضرتك ما عملتش مسلين بلو تيست بعد ما خلصت ليه؟
It's very good questions, but it looks like all right tube. So I can confirm to you that actually most likely they will do it, but it looks like it was like
documentation at least, yeah. As a documentation at least.
You are right in that. You are right.
Thank you.
Any more questions, guys?
Dr. Yusri, it is not a question, but it's a request. I just want to see one of your operation with endometrioma, whatever the size of it, how.
Inshallah, we have another operation day in November. We'll try to get you a myomectomy and endometrioma. Inshallah, Bismillah, we are trying every other month to do operation day live, to cover most of the surgery. Inshallah, in November, we'll try to make it including laparoscopic myomectomy and laparoscopic endometrioma excisions. But there are, I think this is now the board and the agreement is we're gonna try to make it every other month activities where we'll have live link to Birmingham theaters, where we see 3 patients normally of different complexity, and we'll have a discussions. And one of the things which I like you to all to do is, again, first, the understanding that you can do what you have seen. All what you need is actually to give yourself a space of time and proper understanding, and also to be quiet and a little bit slower in your learning curve. And what is more important than anything is patient safety and producing benefits, not harm. And I always say in my theater, when you come to work with me, you are always free to actually give suggestions, and you're always free to give something which might be not the way of my doing. And I always pause and address it, because it's very important to listen. And this is why it is important to have democracy in theater. It doesn't mean that you will lose your leadership, but democracy with leadership means people can talk to you, can actually suggest for you, can even sometimes be harsh with the suggestions, but also at the end, you are leading them. So whatever you decide, you will do. So it's very important to get this balance between being democratic, listening, and actually giving some thought about what the people are saying to you, and indeed having a proper leadership. So any
Thank
more
you so much. Thank
questions? Closure. All right, so it seems that everybody's happy. So thank you very much for today. It was a long day and really appreciate that you are joining us. And hopefully we'll see all of you in near future. Thank you very much. And thanks,
many thanks.
Dr. Ahmed. Well, thanks, Dr. Islam, for the effort of making this from your end actually working. And hopefully next time, all the problem that we have today, voice and mic, etc., will be looked after, so we'll end up having a smoother.
Thank you very much, Professor Afifi.
Thank you very much. Have a good day, guys.
شكرا دكتورة على اليوم العظيم. شكرا جدا.
Waiting for the next live broadcasting, inshallah.
Inshallah, for business. Assalamu alaikum.
شكرا.